Hello, hi, notice everyone. This is Dilip once again. Welcome back to the next session, in the afternoon to evening session of another day. I think people are already there, right? Hi. So let's start with our discussion. All right. Okay. So as I promised, because some were asking about the discussion on cardiomyopathy. So let me mop up anyways with regards to cardiomyopathy, and if needed, I'll be telling about the statin guidelines and shock as well. These are common topics, the shock and all those things. If it's possible, I'll discuss here itself if time allows anyways. So cardiomyopathy means there is some problem in the myocardium as opposed to the infected endocardium. The problem here is going to be in the myocardium. We know that. So either the myocardium can thin out, or myocardium can become hypertrophied, or myocardium can be replaced by something else. Some infiltration can happen into the myocardium. So based on that, we can divide the cardiomyopathy into dilated type of cardiomyopathy, where the myocardium will be thinned out and it will be lost. Then we have something called a hypertrophic cardiomyopathy, where the myocardium may be thickened and hypertrophied. Restrictive type of cardiomyopathy, where the myocardium will be infiltrated by some other substance apart from the myocardium, so that your myocardium may be either dilated or hypertrophied. That varies anyway in restrictive cardiomyopathy. So based on that, we can divide into three. So of course, we have the DCM, that is dilated cardiomyopathy. Then we have the HCM, that is hypertrophic cardiomyopathy. Then we have the RCM, that is restrictive cardiomyopathy. As I told you, here the problem is in the dilation of the myocardium. So that's going to be the issue over here in DCM, whereas in HCM, as we talk about, it's the hypertrophy. That's going to be the most important problem here. As far as RCM is concerned, it's infiltration by some other substance, as we have been discussing for a long time. So let's finish off the DCM first. I'm going to tell some of the causes that are going to be associated with dilated cardiomyopathy. First of all, you need to understand that there will be ventricular dilatation, and there will be, because of that, there will be reduced contractility, which means this is a problem of systole. So predominantly these patients will be experiencing systolic dysfunction. That's because of dilated heart and reduced contractility. But remember, the patient should not have ischemic heart disease. In the sense, I can write it's not due to ischemia, in the sense like the patient should not have any significant coronary artery disease. That's a very important point. Apart from that, patient should not have any valvular heart disease, or the patient should not have any significant hypertensive heart disease. So this is a very important rule. So only non-ischemic dilatations should be called as DCMs. So non-ischemic dilatations is what we refer to as DCMs, and ischemic dilatations will be dealt in a separate way. Like it's an ischemic cardiomyopathy, and that should be something separate. It should not be confused with the non-ischemic dilatations, which should be called as dilated cardiomyopathy. Very, very important point. Among these three, if you ask about the most common cardiomyopathy, what will you answer? Among these three, talk about DCM, HCM, and RCM. So what is the most common cardiomyopathy among these three? Any idea? Of course, yes. DCM is going to be the most common form of cardiomyopathy. But remember the fact, but if I ask you what is the most common cause of cardiomyopathy, you should answer ischemic cardiomyopathy. Ischemic cardiomyopathy is the most common cause of cardiomyopathy, basically, because we know how much ischemia is common. But if you ask among these three, which is the most common, I will of course tell DCM is the most common. Among the dilated cardiomyopathy, you have many different types are there. But if they ask you the most common cause of dilated cardiomyopathy, what is the most common cause? There are many causes out there, which we'll be discussing subsequently. What is the most common? Of course, it's not alcohol. It is basically familial. And previously, this group of disorders were supposed to be idiopathic in nature. So that's supposed to be the most common cause. In fact, 40% of all the dilated cardiomyopathies are contributed by familial causes only. So there are more than 30 genes are there, which are implicated basically in familial cardiomyopathy. But I mean, understanding those genes are really not important. Majority of them are structural and nuclear proteins. Most of them are structural. I mean, if they tell you sarcomeric proteins because of those mutations, if you get cardiomyopathy, that is usually a hypertrophic cardiomyopathy. It's due to sarcomeric proteins. But if they talk about the structural and the nuclear proteins, if that is causing cardiomyopathy, very likely to be a dilated cardiomyopathy. Yes, laminin A and C are common, but only one textbook tells laminin group of proteins are commonest. But majority of the genetic studies tell that we need more studies. That's all. With preliminary studies, we cannot really tell what is the most common type of mutation. But of course, you have a lot of mutations. A lot of structural proteins and nuclear proteins are involved, which can result in development of dilated cardiomyopathy. All right. So currently we have a separate group of disorders called idiopathic cardiomyopathy, idiopathic DCM. Currently it's only 20%. Previously, most of the familial cases are thought to be idiopathic because we didn't understand about the genes. That's what I was trying to tell from the beginning. But we have a separate idiopathic right now. If it doesn't fit into any of the diagnosis, then it could be idiopathic. Then, of course, number 3 is going to be the myocarditis. That's going to be the third most common after this familial and idiopathic. So certain myocarditis, as a sequel of myocarditis, you can result in cardiomyopathies. Of course, myocarditis can be caused by many agents like viruses. If you ask about what viruses are common, the same thing that causes pericarditis, like parvovirus and your HHV6 are going to be more common. Previously, it was thought that Coxsackie virus are going to be the most common, but currently it's not. Parvovirus and your HHV6 are going to be the most common. In fact, if you want to choose one answer, choose parvovirus B19. Then you have HHV6, then you have Coxsackie virus group, then you have many other virus groups like HCV also recently has been proposed to cause cardiomyopathy. Then you can get with adenovirus, you can get with echovirus, you can get with cytomegalovirus. A lot of viruses can cause myocarditis. It can be variable. The clinical course of myocarditis is completely unpredictable. Virus is going to be the most important. As far as the viral cardiomyopathies are concerned, the clinical course is extremely non-predictable. It can be subacute to fulminant form of myocarditis. Of course, as the name suggests, which is going to be most problematic, which means subacute myocarditis is problematic or your fulminant myocarditis is problematic. Subacute or fulminant? Yes, so many people are answering that fulminant myocarditis is more problematic, but actually no. Fulminant myocarditis generally tends to respond well. Subacute actually is going to be more problematic, and it's going to be one of the most important reasons for chronic heart failure. But fulminant, because it presents with a more inflammation and it's present more acutely, we are able to control that with steroid use. Steroids will treat it usually. Even though fulminant comes with severe LV dysfunction, but they will not have LV dilatation. There are two things that are happening. For example, if you talk about fulminant versus subacute, subacute tends to present with a dilated LV, but they won't have an edematous LV. Generally, they tend to have only mild to moderate LV dysfunction. Moderate LV dysfunction, right? So whereas fulminant is going to present with a normal LV, or we can tell edematous LV, but the size will be normal. There will be no dilatation, but they will have severe LV dysfunction. Severe LV dysfunction. But remember, they will have more inflammation. So you will be treating with steroids more acutely, and you will be using a high dose steroid. So recovery will be very good, and the long-term prognosis is very good. But here, steroids are less beneficial. They're not going to be very beneficial. And of course, the recovery is poor in these conditions. Here, the recovery is good basically once you treat with steroids. So that is why overall, if you take the mortality wise, the subacute is going to be more problematic compared to that of fulminant type of myocarditis that we encounter. And more than that, what is the most common cause of a transplant in the world? Cardiac transplant in the world. I'm not talking about India. Most common cause of cardiac transplant in the world is DCM only. Most common reason for doing a cardiac transplant. Very important point. This could be a question in the exams as well. Most important reason that dilated cardiomyopathy is the most common reason for doing a cardiac transplant in the world. And you can get with bacteria also. Certain bacteria can produce myocarditis. Can you tell what bacteria? Some bacteria that are important in causing myocarditis. Okay, diphtheria, everyone knows. Diphtheria produces paralysis, myocarditis. Fine, all right. Apart from that, but diphtheria we don't see very commonly right now, isn't it? Yes, Lyme's disease is what I'm expecting. Okay. Lyme's disease can cause, then a lot of rickettsial infections can cause, tuberculosis itself can cause myocarditis. There are fungal myocarditis also possible. Then more importantly, I need to tell this separately. Even the HIV is a virus, this is a special cause, HIV related myocarditis, very common in many patients suffering from HIV. It can happen even with a normal CD4 count. Fine. Then of course, Chagas disease. These are the 4 things I need to really emphasize on. Among these 4, virus, of course, is the most common. And you can separately remember bacterial. In that, the most important is going to be the diphtheria and the Lyme's disease. Only 2 things in bacterial that is very important. Then you can get with HIV and probably with Chagas disease also. All right, but Chagas disease, you know, so they're not going to involve the heart only. They are also going to produce megaesophagus as well as the megacolon also. So the dilation of the esophagus and the colon also will be there. Heart also will be dilated. Esophagus also will be dilated. Colon also will be dilated. It's caused by Trypanosoma cruzi. We know that. And remember, Chagas disease diagnosis and exam should be made only after travel to South America. That's very important because Chagas disease is not endemic in India right now. If you have a strong history of travel towards South America, where it is endemic, so in that setting, you can diagnose a Chagas disease. Otherwise, it's not good to diagnose Chagas disease as far as exams are concerned. Cool. Then syphilis, I don't think it will cause direct cardiomyopathy. Syphilis more often will cause of a aortic aneurysm. Root dilatation is very common with syphilis, but I don't think really they will cause myocarditis. Then alcohol, a lot of toxins like alcohol can cause myocarditis. For alcohol to produce myocarditis, how much you need, how much alcohol to be taken? So typically you should take at least 90 grams for a period of 5 years. This is the minimum requirement. 90 grams of alcohol, which will be translating to approximately 8 drinks per day. Approximately 8 drinks per day for a period of at least 5 years you need to take to develop this alcohol-related cardiomyopathy. That is toxic cardiomyopathy. And apart from alcohol, it can be caused by other toxins like cocaine also. Cocaine used for a long run can also result in cardiomyopathy and a lot of chemotherapeutic drugs. This is very important for exams. So what are the chemotherapy drugs that can cause cardiomyopathy? 2 drugs I'm expecting. Third, if you don't tell, it's fine. 2 drugs I'll be expecting. One is, of course, yes, doxorubicin, that is anthracycline drugs. Second one, very good, trastuzumab. Guys are very improved right now. Trastuzumab. Yes. Cyclophosphamide, yes, plus or minus third, you can write cyclophos, but these are the 2 things that are important. But can you tell what is the difference between this anthracycline causing cardiomyopathy and trastuzumab causing cardiomyopathy? Yes, it's all about the reversibility, correct? So anthracycline is basically reversible, whereas trastuzumab cardiomyopathy is something that can be reversed. So that's important. So reversibility is the key here. So apart from toxins, what else you have? You have some autoimmune process which can cause dilated cardiomyopathy. Variety of autoimmune process can cause cardiomyopathy, like many collagen vascular disorders, connective tissue disorders. I can write CTD itself in the first place, like polymyositis, scleroderma, can cause dilated cardiomyopathy. Alcohol is a cause of myocarditis or DCM. No. We have finished myocarditis now. We are not moving on to myocarditis. We're not talking about myocarditis. We're talking about cause of DCM now. That's separate. Don't confuse this with that. Then autoimmune causes. Many connective tissue disorders can produce cardiomyopathy, like you have polymyositis, systemic lupus erythematosus, scleroderma, rheumatoid arthritis. Then a lot of vasculitis can cause cardiomyopathies. Like most importantly, I'll be talking about Chuk's-Strauss syndrome. Chuk's-Strauss syndrome can cause myocarditis as well as Chuk's-Strauss syndrome can cause dilated cardiomyopathy also. Remember, most common cause of death in Chuksta syndrome is cardiac death only. Myocarditis, cardiomyopathy, and death is the usual cause of death in Chuksta syndrome. That's why Chuksta is very important here. And polyarteritis nodosa can also have a decent amount of cardiac involvement. So these are the two vasculitides I need you to know. One is Chuksta and second is polyarteritis nodosa. Then we have another type of cardiomyopathy called as peripartum cardiomyopathy. So peripartum cardiomyopathy is probably thought due to prolactin in certain individuals may be reacting badly. So this is the current theory. That's called a prolactin theory, where they believe that prolactin is a cause of cardiomyopathy in PPCM, and the timing of peripartum cardiomyopathy is really, really important. So usually it starts 1 month before the delivery, and it can happen anytime up to 5 months after delivery. So this is the timing. So timing is very important. 1 month before the delivery to 5 months after the delivery in the postpartum period, it can happen. That's why it's called a peripartum, not a postpartum cardiomyopathy, because many students think it's postpartum, not postpartum. It's peripartum. It can happen just before the delivery also. And of course, because we think prolactin is a very important reason for development of this peripartum cardiomyopathy, bromocriptine is one of the important treatments. Even though you give standard heart failure treatment, but bromocriptine is supposed to be a very important treatment as far as PPCM is concerned, where 70% of the patients will respond to bromocriptine therapy. Remember, 1/3 of the patients can have recurrence in the next pregnancy. So previously, peripartum cardiomyopathy was a contraindication for next pregnancy, but currently it's not a contraindication, but you have to warn the patients for sure. And recurrence is more in patients who are having an occult LV dysfunction. Those who recover the LV function completely, usually 66, that is 2/3 of the patients will will get the LV function back completely, but 1/3 of the patients may not get the LV function back completely. So those patients, you have to advise that next pregnancy you can get disease in a more severe way also. So it's not a contraindication for pregnancy, but you have to warn them for sure. And you have other types. Another type of autoimmune type, another type is there, that's called the giant cell myocarditis. It's one of the fulminant types of myocarditis, which can even result in death of the individual also. Mostly, it will be fulminant. And biopsy will show the accumulation of giant cells with granulomas. That is why it is called as giant cell myocarditis. Mostly these patients will go for rapid conduction blocks and ventricular tachyarrhythmias. Conduction blocks like AV blocks, and they will go for VTVF, and usually they will die. It's very fast and typically presents in the middle age group, around 30s and 40s. Very common in the middle age group. They will die usually. Even though it's one of the fulminant type of myocarditis, you might argue to have a good prognosis, but because we don't even have time to treat these patients, they are very faster in progression and they'll generally die faster. Then we have another type of dilated cardiomyopathy called as stress-induced cardiomyopathy. You know what is that stress-induced cardiomyopathy? We have already studied a lot of things about it. What is that? There's no need to discuss about that right now because we have did a great deal of discussion already. That is Takotsubo cardiomyopathy. Takotsubo cardiomyopathy, that is apical ballooning syndrome, which we have discussed in a great deal. Then we have ARVD, that is arrhythmogenic right ventricular dysplasia, or arrhythmogenic right ventricular cardiomyopathy, or arrhythmogenic right ventricular hypertrophy. You can call in any way. So basically, there will be fat dysplasia, and if you take the right ventricle, so let me draw the right ventricle. I can draw from the side. For example, if you take this is the right atrium, and if you take this is the right ventricle, and this is the RVOT. Now I'm showing the right ventricle from the right side. From this side, if you see the right ventricle, how the right ventricle look like. So this is the pulmonary artery, or you can call it as a right ventricular outflow tract. And from here on, you have the other LV and all the other structures. This is the septum. Clear? So this is the atrium, right atrium, and this is the RV inflow tract, and this will be the RV outflow tract. So if you take the right ventricle in this scenario, so there is something called a triangle of dysplasia, where your ARVC pathophysiology is located at. So usually it is the first point you are going to mark is the infundibulum, and second point we are going to mark is the inferior or diaphragmatic surface of the right ventricle, And third, you are going to mark is the apex of the right ventricle. If you join all these points, you will get a triangle. This is called a triangle of dysplasia. And in this area only, you're going to get the dysplasia, and especially in the form of fibrofatty infiltration of the right ventricle. So that is what we refer to as triangle of dysplasia. That is where you get the ARVD fat dysplasia very commonly. We have discussed already, these patients will get exertional syncope and death. That is because of the development of ventricular tachyarrhythmias, exertional syncope and death. So they will get VTVF during exertion. And characteristically, ECG will show that epsilon wave, which we have discussed already. And MRI is the best investigation of choice. We have discussed already because we need to tell that, presence of fat within the myocardium. And this fatty infiltration will produce RV dilatation and RV dysfunction. And they can go for slow right ventricular failure as well. And at the same time, there is one important genetic syndrome that is associated with ARVD. What is that genetic syndrome? It's very easy. It's present in Robbins itself. So that should not be a tough thing to tell. Yes, it is given in Robbins itself, right? So that's called Naxos disease. That's a genetic form. So where the patients will have ARVD and the patients will have palmoplantar keratoderma. Palmoplantar keratoderma, and patients also will have a kind of a woolly hair. Woolly kind of a hair. So this is the triad of Naxos disease or Naxos syndrome. So which is a genetic syndrome that is associated with the ARVD. And chronic tachycardia itself can produce cardiomyopathy. That's called a tachycardiomyopathy. That's called a tachycardiomyopathy. Chronic tachycardia itself can produce cardiomyopathy. And usually this has a good prognosis because once the tachycardia is reverted and if the rate is controlled, that kind of cardiomyopathy will completely resolve. And some endocrine disorders also can cause dilated cardiomyopathy, like hypothyroidism can produce a type of dilated cardiomyopathy. Then growth hormone excess, acromegaly, we know. I think I've discussed in my endocrine section already in the app. So in acromegaly, you have this kind of LV enlargement and they can produce a type of cardiomyopathy. And pheochromocytoma, because of continuous catecholamine excess, a form of tachycardiomyopathy only, can produce. And certain micronutrient deficiencies can also produce dilated cardiomyopathy. What is the micronutrient deficiency that produces dilated cardiomyopathy? Yes, very simple. That is selenium, given in all biochemistry textbooks. What is the disease called? Yeah, endemic cardiomyopathy, Keshan's disease. And of course, carnitine deficiency can also produce cardiomyopathy. You have to know about that also. And apart from that, there is another entity called LV non-compaction. That's completely an echocardiographic diagnosis. So I don't want to discuss much about that. That's called LVNC. That is called left ventricular non-compaction. Vitamin B1 deficiency will produce beriberi will cause tachycardia. Tachycardia will produce myopathy. Okay, fine, understood. So B1, but I won't tell it as a separate cause, but this is very important. And LV non-compaction. LV non-compaction means, like what happens in the left ventricle in this scenario is, there will be too much of trabeculations. Usually they have trabeculations. There will be too much of trabeculations in the left ventricle. So this is basically LV non-compaction to start with. And this too much of trabeculations will trap some amount of blood, which becomes a source of thrombus, and they can produce cardioembolism and stroke. And at the same time, they has increased risk of ventricular tachyarrhythmias. So this is a separate set of patients, completely echocardiographic diagnosis. That is what we refer to as something called a LV non-compaction. So you have so many causes of dilated cardiomyopathies. As far as DCM is concerned, the causes are the most important. So of course, it should be non-ischemic. So that should be the point number one to note. Then as far as most common cause is concerned, familial is the most common cause. Then you have myocarditis, where some important points regarding myocarditis is important. Then in toxins, alcohol is going to be the most important. Apart from that, this doxorubicin and trastuzumab, very common question exam. Peripartum, role of prolactin could be a question exam. Giant cell myocarditis, you see the giant cells in the endomyocardial biopsy, very important point. Fulminant, rapid death. Takotsubo, we had discussed enough. ARVD, again, Naxos disease and triangle of dysplasia is going to be the most important and the best investigation. And remaining things, Keshan disease may be asked if there is any biochemistry professor setting a biochemistry question, can produce. I mean, neurological disease causing cardiomyopathy is not very classic, because neurological diseases can produce DCM as well as HCM. But still, if you want to write here, you can write neurological diseases, neurodegenerative disorders, especially neuromuscular problems like Friedreich ataxia. Then you have Duchenne muscular dystrophy, Becker muscular dystrophy, myotonic dystrophy. So many neuromuscular disorders can produce cardiomyopathy, dilated cardiomyopathy type also. But they can be producing hypertrophic also, but you can tell no issues, dilated cardiomyopathy. And more importantly, they'll be asking you two things. Of course, I told you for myocarditis biopsy, use something called the Dallas criteria. We knew that already. What is the role of MRI? So this could be an institute question. So this is coming up in a big time. So that's why they might be asking about the role of MRI in this thing. What is that? I mean, diagnosis of dilated cardiomyopathy and myocarditis. So in MRI, you see something called a late gadolinium enhancement. This is a very important point. Trust me, very, very important point. That's called an LG. That's called a late gadolinium enhancement. That is going to be really, really important in the setting of myocarditis diagnosis. And usually whenever you see a late gadolinium enhancement in MRI, it always indicates a scar. They give this word LG, that usually indicates a scar. And depending on where the scar is seen, you can really think about different diagnoses. For example, if you see the scar in the, or if you see the late gadolinium enhancement, don't need to write the scar. So if you see this kind of late gadolinium enhancement in the subendocardial region, or if you see a transmural LG, so usually that goes towards an ischemia. So that's completely different. So that's an ischemic scar. We know that transmural or subendocardial region is always going to go towards ischemia. So that's not here. But what we need to know is non-ischemic types. So non-ischemic types can be seen in the mid-wall, middle of the myocardium. So if you see mid-wall, then that is non-ischemic. Then if you see epicardial, that is non-ischemic. Then if you see global endocardial, LG. So that's predictive of non-ischemic. In this, the mid-wall is the one that tells you probable cardiomyopathy. Or it can be myocarditis. In cardiomyopathy and myocarditis, usually you see in the mid-wall only. So that's why the role of MRI is coming up big time. And epicardial and other areas, like they're very rare. They really don't get. For example, epicardial, if you get epicardial kind of LG, if you get, you can see in Chagas disease. You can see in amyloidosis. And global endocardial can also be a feature of amyloidosis. Then systemic sclerosis. Many conditions can produce this global endocardial kind of a thing. So anyways, fine. So in exam, if they give you this kind of patterns of late gadolinium enhancement, then you can diagnose different disorders. But more importantly, whenever they give LG, it always means it's a dead tissue, it's a scar. That's an importance of an MRI. That is late gadolinium enhancement for that matters. LG, I told you multiple times, that is late gadolinium enhancement in MRI. Clear? From the beginning I was telling. So that's a very important point as far as MRI is concerned. 11L is telling Pompe's disease. Pompe's disease is more of a, I think, hypertrophic cardiomyopathy rather than dilated, but there is substantial overlap. Trust me, it's not that easy to classify a cardiomyopathy. It's a substantial overlap. Absolutely substantial overlap is there. Many conditions that you think it's dilated can cause hypertrophic or restrictive. Also, many conditions you think hypertrophic, they can produce dilated or restrictive type of cardiomyopathy also. Because there is overlap, I'm just telling the important ones. Hemochromatosis, I feel more of a hypertrophic type of cardiomyopathy. I mean, restrictive type of cardiomyopathy, even though it can produce more of DCM as well as RCM. So there are some diseases. For example, let me talk about, you're talking about Pompe's, because many students wanted to know about Pompe's disease. It's an acid maltase deficiency, glycogen storage disease. We know that it can produce HCM as well as RCM, but even though my thing is towards RCM only. And at the same time, you have one more thing. What is that? Hemochromatosis. Once again, it can produce DCM, HCM, as well as RCM. All these three phenotypes has been told, but I go more towards a RCM again for hereditary hemochromatosis. It can produce all three entities. So like this, you have different disorders producing different types of cardiomyopathies. It's not like hereditary hemochromatosis means it should be producing only DCM or HCM. It can produce anything. All these three can be produced, but there is no standard consensus regarding what is the most common and all. Because the moment I tell these things, immediately the PG aspirant will pop up and tell what is the most common then. I don't know what is their like affinity towards the most common, but I don't think no book is giving. If there is any book that is giving HCM is the most common, tell me with reference so that I can include in my next lecture. But as far as I know, I generally take only Braunwald or probably sometimes journals like NEJM as a standard. If it's an NEJM, then definitely I will agree to that because they give a good review. Literature review will be very good in NEJM. And BMJ is also okay. Lancet is also okay. JAMA is also okay. So these journals have a very good literature review. So that's why it's acceptable. But other journals, like especially if you take some Hindavi and all these things, I don't really encourage that because the literature review will be sometimes very poor. And standard textbooks, of course, fine. So when you're going to take evidence from probably standard textbooks like Harrison or probably even from Braunwald, Hurst, then fine because they're going to give a good literature review. But apart from that, we don't really, even I don't accept facts from Washington Manual also because they don't have a good literature review. But if you have a standard textbook or some journal backup, then you can always ping me. So what is the most common cause? Robbins is a very basic level textbook, man. That is for mostly for undergrads. But okay, Robbins can be accepted to some extent. But Robbins are more of a pathology textbooks. What does it matter for a clinician like me? To be honest, I mean, for example, as far as Ashwin is telling Alagappan. Okay, for example, it's a common tendency for a second year and a pre-final year, or even an intern, even at the post-intern level, it's a common tendency to more, incline towards the pathophysiology and more inclined towards the mechanism of action and all this stuff. But students generally don't realize the fact that this pathophysiology and the mechanism of action of a particular drug is not at all going to be important when you're going to treat a patient. So of course, for me, the most important thing is to analyze the pattern of the disease and what diagnosis it fits in, what is the next step I need to do, and probably what is the treatment that is available and what are the options I can select from and what are the side effects that I'm going to encounter so that when the patient comes with side effects, I should be able to identify that particular side effect. So this is all what I'm concerned. I'm not at all concerned with the pathophysiology, irrespective of what gene does what, I don't really care. Because according to a physician, I'm talking from my perspective. I'm not telling that is not important. From a medicine physician's perspective, this is not important at all for me. So that is why I believe that it doesn't help me in my practice. So I stopped that kind of things long time back. But always I believe, like till now, the second year, third year, final year, or even at the post-intern level, they'll be trying to know why mechanism, pathophysiology. To an extent is fine, but it goes to a certain extent that they wanted to research at the atomic level also, which is not really important. So don't unnecessarily waste time, especially if you are a post-intern preparing for a PG entrance. You should ask questions on why, but when you're a second year or a third year, that must be fair. But when you're a post-intern or when you're a postgraduate, ask questions on clinically why, rather than asking questions on cell membrane why it is formed, molecule why it is formed. That is not really fair, especially when you're a postgraduate or a post-intern especially. That's what my opinion is, because students wasting more time on this and forgetting the actual clinical skills. That's what is happening right now. And they are trying to be, there are two groups of physics, isn't it? Theoretical physics and particle physics. So I generally like more of particle physics than theoretical physics, because theoretical physics is totally based on theories. And if it fits into the explanation, then that's fine. But if you go to particle physics, they actually do and smash the particles, and they find out and make conditions that that actually mimic Big Bang, and they want to find out what happened immediately after the Big Bang and all these things. So I believe particle physics is good compared to the theoretical physics. I mean, I'm not coming to that argument, because I once upon a time wanted to become a particle physicist, and with that background only, when I finished my 12th standard, I entered IIT Roorkee. After that, I discontinued because of my mother's wish to become a MBBS student. And I don't know whether it is fortunate or unfortunate. I believe that like a very neutral thing right now. Initially, I thought my whole life was ruined because I became an MBBS student. But I don't know. Later on, I started realizing there is some plus minus. Again, it has to be equalized, and I don't know what I would have done if I had become a particle physicist, but I would have been very happy. So that we got a great faculty. You should tell that, but fine anyways. I mean, everywhere there is struggle. It's not like it is not a struggle. Everywhere is a struggle. I mean, sometime later I will tell you my story also, so that at least you will understand what life is at least. Anyways, let us move on to the hypertrophic cardiomyopathy and how we're going to treat this dilated cardiomyopathy. Treatment. So I can write on the side. So investigations, I told you, are going to depend typically on the echocardiogram. In the echocardiogram, what you're going to see is typically LV dysfunction or an RV dysfunction. So in the sense, I'm talking about a systolic dysfunction here. Systolic dysfunction. If there is a systolic dysfunction, automatically I'm going to have a low ejection fraction. So this is point number one. Apart from that, I can also see the myocardial thinning. Myocardial thinning, this is an optional. Remember, this is not always. But myocardial thinning goes more towards a dilated cardiomyopathy. That's a very important point. This can be looked in MRI also, myocardial thinning, but again, very important. And at the same time, you can do MRI and look for the late gadolinium enhancement, that kind of a pattern. And MRI also, you can look for the thinning of the myocardium. The myocardial wall can be thinned out, so that can be looked in the MRI as well. And at the same time, you can see some changes in the echocardiogram also. As far as LV dilatation is concerned, you can get bundle branch blocks very commonly. In fact, LBB and RBB are extremely common. Whenever the heart is getting dilated, the bundle branches become stretched, and sometimes they can be teared off, and you can get bundle branch blocks and conduction delays, low voltage complexes. Absolutely all these things are possible. So as far as the ECG changes are concerned, I'll be more seeing BBBs, bundle branch blocks, conduction blocks, and I'll be seeing atrial fibrillation, very, very common in the setting of a DCM. And at the same time, I can see low voltage complex, one of the important cause of low voltage complexes, which I have discussed already. I think I didn't tell this. One of the student actually told dilated cardiomyopathy produce low voltage complexes. Correct. I remember one student told me. They have commented. So low voltage complexes are possible in a dilated cardiomyopathy as well. Yes, Goldberger triad. Then you have the endomyocardial biopsy, EMB. So yield is very poor. In myocarditis, it's very good, but only in selected cases, you're going to do endomyocardial biopsy. For example, in giant cell myocarditis, if you don't have the clue, then you can find out. Then in certain patients with probable myocarditis, if you do the biopsy, then there might be yield. Apart from that, routinely doing endomyocardial biopsy is not going to be that beneficial. Yield is only hardly 5-8%, not more than that. So there's no much need unless and until you need for some selected cases. Coronary angiography, of course, is more important. Once again, in selected cases, that is to rule out significant ischemic heart disease. Remember, only when you rule out significant ischemic heart disease, you can diagnose a dilated cardiomyopathy. Otherwise, it's not possible to diagnose dilated cardiomyopathy. And apart from that, what else is there? You can do investigations to rule out other conditions like hypothyroidism is there, right? So if you suspect hypothyroidism, you can do TFT, growth hormone testing can be done. You can do urinary metanephrin to rule out pheochromocytoma if the clinical situation is warranting. So investigations will be usually done based on what is your suspicion. Basically, that's all. But echo is going to be the most important investigation as far as the DCM diagnosis is concerned. Is there any role for genetic testing? It's coming up big time, but currently it's not routinely done. Again, only in selected cases we are going to do the genetic testing as well. As far as treatment of DCM is concerned, most of the DCMs are probably not reversible. You cannot reverse to a great extent except few DCMs, but you're going to treat same as like that of the heart failure with reduced ejection fraction. Almost same treatment. There is no specific treatment as far as DCM is concerned. For example, you can prefer immunosuppression for myocarditis. If you pick up very early, especially for fulminant forms of myocarditis, you can treat with steroids. As I told you, immunosuppression may be helpful. For example, in peripartum cardiomyopathy, as I told you, bromocriptine may be helpful. Sometimes even IVIG, because peripartum cardiomyopathy is also thought to be one of the autoimmune process. So IVIG may be beneficial in peripartum cardiomyopathy. But apart from that, most of them are not really treatable. So it's very difficult to reverse the dilated cardiomyopathy. Anyway, prognosis is going to be absolutely variable depending on the cause of the dilated cardiomyopathy. So I'll tell you only the important treatments. Steroids are beneficial only in fulminant type of myocarditis. As I told you, in subacute forms, like viral forms are generally supposed to be subacute. In subacute forms of myocarditis, generally they don't respond very well. And probably bromocriptine and IVIG can be tried in patients who are having PPCM, peripartum cardiomyopathy. IVIG in severe cases only. So this is other than that, you are going to treat the same way as how you are going to treat a heart failure with reduced ejection fraction. So as far as DCM is concerned, the causes are going to be the most important. But on the other hand, when you come to hypertrophic cardiomyopathy, they'll be asking you so many things. So hypertrophic cardiomyopathy is basically can be divided into two. Hypertrophy that can be called as cardiomyopathy and hypertrophy that cannot be called as cardiomyopathy. That's really, really important. So first of all, HCM in the sense, you have again two types. One is called hypertrophic obstructive cardiomyopathy. And second, you have non-obstructive types. So I can write obstructive and non-obstructive types. Obstructive and non-obstructive types. First, you need to know when you will call it as an obstruction. So here we mean the LVOT obstruction. Remember, this LVOT obstruction can be present at rest or can be present only with dynamic maneuvers like exercise. So either the LVOT obstruction is present at rest or at exercise, doesn't matter. It will be called as a hypertrophic obstructive cardiomyopathy only. But you have certain non-obstructive variants of hypertrophic cardiomyopathy as well, which is also quite common. This form of non-obstructive variants are still there in India also. In fact, in Asians, non-obstructive variants are quite common, even though Western textbooks give 70% of them are obstructive and 30% are non-obstructive. But as far as I am known, in Indian patients, especially Asians, this kind of non-obstructive variants are more common. For example, we have a type of cardiomyopathy called as apical HCM, otherwise referred to as Yamaguchi disease, because this was first, discussed in the Japanese population only. You have Yamaguchi criteria is there. That is for adult onset Still's disease. So which will be discussing rheumatology. Adult onset Still's disease, the criteria is called as Yamaguchi criteria. But here in apical HCM, that is also referred as Yamaguchi disease, but that's an example of a non-obstructive type of cardiomyopathy. But nevertheless, both whether obstructive or non-obstructive doesn't matter. Both these types of cardiomyopathy, the most important problem is the diastolic dysfunction. Diastolic dysfunction is going to be the most important here. So that's the problem. So that is what is going to be the clue here. But obstructive cardiomyopathies are going to be at more risk of death because of the dynamic LVOT obstruction, which we'll be discussing subsequently. Non-obstructive types, still they can produce diastolic dysfunction and they can produce heart failure with preserved ejection fraction, which also should be known. So both are problematic only, but obstruction means there is going to be more risk of death due to arrhythmias and syncope. There is very, very high risk of death if it's an obstruction, especially if the obstruction is present at rest, then the risk of death is extremely, extremely high. So that's where the problem is. The usual analogy. So why we, and what is the problem in telling what this exact incidence of obstructive versus non-obstructive is because we do only the resting echocardiogram. Nobody does then exercise echocardiogram or a stress echocardiogram. So that is the idea, so when you do a stress echocardiogram only, you can identify this subset of patients who are going for LVOT obstruction only during exercise. Otherwise, you will not be able to find out that. So that is why currently, before telling it's a non-obstructive type of HCM, it's better to do an exercise echocardiography or a stress echocardiography, where if you find out the LVOT obstruction during exercise, then again it will be put under HOCM only, hypertrophic obstructive cardiomyopathy. Previously, there was another name for hypertrophic obstructive cardiomyopathy that's called idiopathic subaortic hypertrophic cardiomyopathy. That is called subaortic stenosis. That's called something subaortic, right? Yeah, idiopathic hypertrophic subaortic stenosis. That's called IHSS. Previously, idiopathic hypertrophic subaortic stenosis. That is the other name that was given previously. But currently, the new name is HOCM, hypertrophic obstructive cardiomyopathy. And there are many other causes of hypertrophy apart from your hypertrophic cardiomyopathy. Like, for example, you have LVH due to systemic hypertension. So I can write systemic hypertension. That will not be coming under hypertrophic cardiomyopathy. Very important to understand. And there is a hypertrophy of the heart due to elite athletes. That's called an athlete's heart. That also will not come under the hypertrophic cardiomyopathy. And there are some conditions that can also produce, most of the time it will be genetic familial only. Hypertrophic cardiomyopathy is whatever we are talking about. And it's an autosomal dominant disorder due to sarcomeric genes, involvement of the sarcomeric genes. If they ask you the most common sarcomeric gene that is involved in hypertrophic cardiomyopathy, it is beta myosin heavy chain. That is called MHC beta. So that is beta myosin heavy chain. Clear? So beta myosin heavy chain, so I'll write it. It's better. Otherwise, you can confuse with major histocompatibility complex. So that is myosin heavy chain. Beta, that is beta myosin heavy chain. So this is going to be the most common gene that is associated with this hypertrophic cardiomyopathy in the first place. And there are many other sarcomeric genes are there that can be involved in the development of hypertrophic cardiomyopathy. So more importantly, being a Mendelian disorder, you'll be having a strong family history for sure, no doubt about that. But usually Mendelian disorders tend to be monogenic, single genes. But this is an exception because you're going to have a multiple gene involvement. It's a multiple gene disorder. So many genes are involved, but most commonly this myosin heavy chain beta, but there can be multiple gene involvement can be there in the setting of a hypertrophic cardiomyopathy. Apart from that, there are some other diseases that are known to produce hypertrophic cardiomyopathy, like hereditary hemochromatosis. Then, as he told you, you have Pompe's disease. Remember, hereditary hemochromatosis can cause HCM as well as RCM. And Pompe's disease also can produce HCM as well as RCM. And you have neuromuscular disorders which can produce DCM as well as HCM. So there are a lot of overlap between them are there. But even though for exams, as far as I know, for HSC, I can answer RCM, Pompe's I can answer RCM, and neuromuscular disease I can answer DCM. But there are substantial overlap between each and every of these disorders. And apart from that, you have another disease that is important that is called a Fabry's disease, which can produce hypertrophic cardiomyopathy or HCM. So what is Fabry's disease? What is the enzyme that is deficient in Fabry's disease? So that is for you. Yeah, it's an alpha galactosidase deficiency. Because it's enzyme deficiency, it must be autosomal recessive. Alpha galactosidase deficiency. So if it is going to be an alpha galactose deficiency, what is going to be the treatment? So, in fact, this is one of the important questions in exam, because this is a reversible form of cardiomyopathy. Because if you give, sorry. Many people are telling it X-linked recessive. Then, of course, you are good in biochemistry. Then I must be only wrong. Okay, I'll change and write as X-linked recessive. Okay. So I'll check back and I'll look back and come back to this as well. Anyway, so it is a reversible form of cardiomyopathy. So what do you mean by reversible form of cardiomyopathy? It means treatment will completely reverse these forms of this form of cardiomyopathy. In a sense, if you start with the treatment with the enzyme called, we have fibrazyme, that's a recombinant galactase beta. If you treat with that enzyme, the cardiomyopathy can completely reverse. So that's why this is important. This is a reversible form of cardiomyopathy. And you have a classic triad of Fabry's disease. So where you have this hypertrophic cardiomyopathy, along with that you will have peripheral neuropathy, and you have basically hyperkeratosis. So this is a classic triad of Fabry's disease, and because it presents in adults, I mean, I feel it's important for me because I have seen some 2-3 patients with Fabry's disease who are coming with cardiomyopathy. So this is a classic triad as far as Fabry's disease is concerned. And as far as overall HCM is concerned, familial HCM contributes only 50%, and please understand 50% of HCM can be sporadic also. So which means not all the cases are going to be familial. 50% can be sporadic also, but the genetic involvement will be the same. So the sarcomeric gene involvement will be the same. So, but it can come sporadically without any familial background. So only familial is 50% only, remaining 50% are sporadic. Anyways, this is quite complicated, but the most important thing is to understand what is HCM and what is not HCM. At the same time, in the HCM itself, it is important to understand what is hypertrophic cardiomyopathy and what is non-hypertrophic cardiomyopathy. Triad you want to repeat, it is a triad of hypertrophic cardiomyopathy, peripheral neuropathy, and skin problems like hyperkeratosis. This is the characteristic triad of Fabry's disease. Then what will be the clinical manifestations? Before that, what is the pathology here? The pathology, we have studied about the genetic mutations, all right. But more importantly, if you take the pathology, there will be something called a myocyte disarray. Even though there are some fancy names given to this myocyte disarray, like helter-skelter myocyte disarray, but the most important pathology here is the myocyte disarray. That's the reason for this kind of hypertrophy in the first place. So this is going to be the basic pathology. That is myocyte disarray, also referred to as helter-skelter myocyte disarray. And this myocyte disarray is the reason for development of hypertrophy also, number one. At the same time, this myocyte disarray is the reason for development of arrhythmias also in this particular patient. They form an arrhythmogenic area, this myocyte disarray areas. They form that nidus for developing this re-entry circuits. So that is the reason why that point is very important, that myocyte disarray. I mean, that's why I remember basically, because that's the reason for development of hypertrophy as well as the reason for death in these patients, that is arrhythmia. So let us see the clinical features of hypertrophic cardiomyopathy, no matter what. So as far as the clinical features are concerned, most of the patients will be asymptomatic. They won't be having any symptoms at all. Few patients who are having symptoms, most of them will be having symptoms due to diastolic dysfunction. Symptoms of diastolic dysfunction, like symptoms of heart failure, like they can have fatigue, they can have breathlessness, especially exertional dyspnea. So this is going to be the usual symptoms. And they can develop this LVOT obstruction also. So once they start developing this LVOT obstruction, they start developing angina, similar to that of how you develop in aortic stenosis. And at the same time, they can develop syncope, and they can develop arrhythmias also. Arrhythmias as well. Clear? Like VT, VF, and all these things. The reason for syncope is also arrhythmias only. So you can put under same entity also. So what is the reason for angina? Reason for angina is many. One is reduced cardiac output. Because of reduced cardiac output, there will be reduced cardiac blood flow. And second reason for angina is they can have severe left ventricular hypertrophy. Because of severe left ventricular hypertrophy, there will be increased microvascular compression. We know that I told you in the first day of cardiology, I told you this, there will be increased myocardial microvascular compression. Because of increased microvascular compression, they can develop left ventricular, anginal pain also. And some few patients may have coronary artery disease as well. So these are the some of the reasons for development of angina in these patients, but nevertheless, they are going to present with this kind of picture only. Remember, this arrhythmias can precipitate sudden death also. So, and there can be family history of sudden death as well. If the disease is familial, if it is coming in a familial fashion, then you might even encounter a family history of sudden death as well due to arrhythmias like VT and VF. And most of the times, this arrhythmias that happen in HOCM is going to be exertional, which means when the patient does some exercise or does some heavy activity, they're going to result in the development of arrhythmias in the first place. Okay. So what are the findings? The physical findings are going to be important as well, examination, because that's a very common question in multiple exams around the world. Every time they ask about HOCM only. So HOCM is a disease, whenever you have hypertrophic obstructive cardiomyopathy, now we are not talking about a non-obstructive variant, we're talking about an obstructive variant, because non-obstructive does not give any much clinical findings, but still they are having risk of diastolic dysfunction, heart failure and death. So that's different. But as far as obstructive variants are concerned, their most important and authentic feature is going to be the dynamicity. So that's going to be the most important. Usually, how can you explain this dynamicity is the fact that usually my best view will be parasternal long axis view. I can draw the heart like this in parasternal long axis view. So let me draw the left atrium here. So this is a very worst left atrium. So let me draw the left atrium here. And this is going to be the mitral valve leaflet. So I can draw in an open fashion. So let me draw the mitral valve leaflet here. This is basically the parasternal long axis view. And you have this outflow tract here. This is the aorta. And this is the LVOT, left ventricular outflow tract. And you know this is the septum, right? So what is the basic problem in the setting of HOCM is the fact that this septum will go for hypertrophy. This is what we refer to as something called a ASH, that is asymmetric septal hypertrophy. By definition, the septal thickness will be at least more than 1.3 centimeter or more than 13 millimeter. This is a characteristic feature of like your HOCM and any HCM. Asymmetric septal hypertrophy is really important. And why we call it as asymmetric? Is there any reason why we call it as asymmetric? Why we call it as asymmetric? Because only certain areas of the left ventricular wall will be thickened. For example, the anteroseptal wall will be thickened in comparison with the posterolateral wall. Posterolateral wall, which means the anteroseptal wall is going to be significantly thickened compared to the posterolateral wall. So there is a ratio also. Suppose if we take the ratio of anteroseptal wall to the posterolateral wall, the ratio will be more than 1.3:1. That's again important. And because of that, sometimes this asymmetric thickening of the septum may create a sort of LV obstruction. You can see here, the outflow tract obstruction can happen. Not always. I mean, only in obstructive variants, this outflow tract obstruction will happen. So that is called the LVOT obstruction, LV outflow tract obstruction, and this will result in significant left ventricular hypertrophy. And in the sense, like most of the times, the LV thickness will be more than 1.5 centimeter. That's also very important. In these patients, left ventricular thickness will be more than 1.5 centimeter. Remember, in dilate cardiomyopathy, the thinning of the myocardium is happening, whereas in LVH, whereas in hypertrophic cardiomyopathy, the thickening of the myocardium is what is happening. So the thickness will be more than 1.5 centimeter. And again, this thickness will be involving more in the anterior wall and the septal wall only. Relatively, your posterior wall. So this wall is what we refer to as posterior wall. And this will be relatively spared. And this will not involve in that much of thickening. So that's why I told you there will be asymmetric septal hypertrophy and asymmetric LV hypertrophy, where the anteroseptal thickening will be more compared to the posterolateral area. So the posterolateral wall thickness will be much lesser compared to the anteroseptal wall. And this creates a sort of dynamicity, and this is what is important for us. So if you really wanted to talk about where to look out for, and this can be a useful idea. Where to look out for. So if you take a parasternal long axis view, I mean, this is a view I prefer generally. So if you take a parasternal long axis view, what you see really is this is the right ventricle, and we're talking about the left ventricular outflow tract here, and this is the aorta, and this is the left atrium, and this is the inflow that is coming inside, and this is the outflow that is going outside. So why this is preferred is because I can find out the septal thickness. If I freeze, I can find out the septal thickness here, and this is going to be the posterior wall and the inferior wall of the left ventricle. So I can find out the posterior wall also. So I freezed it, so I can see the posterior wall here. I can see the septal thickness here. So I can find out exactly what is the posterior wall thickness. At the same time, I can find out exactly what is the septal thickness also. So I know the septal thickness, if it is more than 1.3 centimeter, that goes towards hypertrophic cardiomyopathy. And if the septal to posterior wall thickness, if it's more, I mean, if the ratio is more than 1.3, then I can again think about asymmetric septal hypertrophy. And at the same time, to prove this dynamic obstruction, there is one thing that is called as systolic anterior motion of the anterior mitral leaflet. Normally during the LV systole, what should happen is your mitral valve should close. That's what should happen. Normally that's what should happen. The mitral valve should close during the systole because blood is moving. Blood is moving like this, and this increased pressure should close the mitral valves basically. But what happens is, because of the obstruction, this movement of blood, this blood movement happening across the LVOT has to pass through this kind of a narrow orifice. Because it passes through a narrow orifice, as I told you by our Bernoulli principle, whenever that passes through a narrow orifice, they create a high velocity, and in that zone, there will be a low pressure zone. That is a Venturi effect, or you can call it as a Bernoulli effect. So this kind of high velocity that is generated and low pressure that is generated in the LVOT, left ventricular outflow tract, is going to suck this anterior mitral leaflet. This is the anterior mitral leaflet. This is going to suck the anterior mitral leaflet towards the LVOT. And actually, the sucking of the anterior mitral leaflet towards the LVOT is going to cause more issues, because this anterior mitral leaflet, once it goes and impinges on the left ventricular outflow tract, that is going to cause more and more obstruction, and that's going to cause more and more problem. And second problem that you can get is, in this condition, only the posterior mitral leaflet. So this is the posterior mitral leaflet. Only this will close properly. So AML will not close properly. So that abnormal movement can result in development of mitral regurgitation as well. So this is what is happening. So in echocardiogram, what all I can look for is the septal thickness, posterior wall thickness, and that SAM of AML, and I can look for the MR jet also. Everything can be looked in the parasternal long axis approach. That's a plaques approach. That's why whenever I want to diagnose HOCM, I use only two views, parasternal long axis approach, and second is I'm going to use this probable apical view. Apical view is also one of the good views to see the LVOT obstruction. But many of the things can be diagnosed with the plaques views itself. Do you understand? I mean, must be difficult, but I think explanation must be easy. Do you understand this? What's happening? Yes, this is what is happening here. So this is a plaques view I drawn you, and this must be easy from now on. So what are the things that's happening? First thing, that's echo. So let me finish off the examination first. In the examination, because of the left ventricular hypertrophy, I'll be having a heaving type of apical impulse. But more importantly, in exam, if they give you something called a double or a triple apical impulse, that usually goes towards a HOCM. Double or a triple apical impulse. If they give any of these words in exam, that goes towards hypertrophic cardiomyopathy. That's an HOCM. And apart from that, you're going to typically see something called a systolic ESM, ejection systolic murmur. And it's a crescendo decrescendo murmur only, like aortic stenosis. But where the murmur will be and what is the difference from aortic stenosis? The murmur will be located more in the left lower sternal border. It will not be located in the right upper sternal border like you see in AS. AS, you will see here. The murmur in right upper sternal border is classic, but in HOCM you will be seeing in the left lower sternal border. And at the same time, the murmur will not radiate to the carotids. That's very important. Whereas in aortic stenosis, the murmur will radiate to the carotids, whereas in HOCM, your murmur will not radiate to the carotids. Instead, the radiation may happen to the axilla and the back. Because this is a posterolateral, I mean, there will be MR jet also here. There will be posterolateral jet. Apart from that, this murmur that is due to that LVOT obstruction will be radiated to the axilla, not to the carotids. Carotid radiation will be not there. And that's one of the important differences with aortic stenosis. And third thing that is very important is the dynamic auscultation. Dynamic auscultation. So this is going to be the most important. As I told you, the name HOCM means you have to prove its dynamicity. It's extremely dynamic. And through dynamic auscultation, you can see the visible changes that are happening in the murmur. So for example, HOCM is one condition where it is actually preload and afterload dependent. So the word HOCM, everyone knows it's obstructive, but as far as the dynamic auscultation is concerned, I used to call it opposite. You can remember as hypertrophic opposite cardiomyopathy. So what do you mean by hypertrophic opposite cardiomyopathy? Which means everything is going to be opposite. For example, let us see what will be the, changes in the load of the heart. And what about the changes in the murmur intensity? Which means I can tell murmur and obstruction together, because when the obstruction increases, murmur increases. Obstruction decreases, murmur is going to decrease. Load, for example, the preload is decreasing. Preload is decreasing, obstruction is going to increase, and the murmur is going to increase. As the preload increases, murmur will decrease. If the afterload increases, murmur will decrease again. If the afterload decreases, murmur will increase again. Which means you can see at every areas, you're having opposite arrows. That's why I told you it is hypertrophic opposite cardiomyopathy and it's not hypertrophic obstructive cardiomyopathy. So that's one point that you need to know. So why this is happening, why it is a highly preload dependent condition, because of that movement of the septum only. So whenever you take this LVOT again, if you draw this LVOT one more time or the final time, so this is going to be the outflow tract and this is going to be the inflow tract. So if you have a significant obstruction at the LV outflow tract, significant obstruction at the LV outflow tract, the preload really matters here. Suppose if your preload is increased in this situation, your volume of the left ventricle will become increased, so that your aortic orifice also will come out a little bit like this. So which means the obstruction is actually relieved. So your blood can move easily. So the obstruction is less, so the murmur will reduce. And this same principle is important for understanding the risk of death as well. Suppose if the preload is going to be less, the reverse is going to happen. The preload is less, then the reverse is going to happen. So in this situation, the ventricular size will be very less. So because of that, your obstruction will actually increase, as denoted in this particular image. So if the preload is less, the ventricular size will be less. My God, my spelling is very bad. Okay. If the preload is less, the ventricular obstruction is less, more, so that it's very difficult to get out of this obstruction. So basically this is a preload dependent condition, and you can think it as an afterload dependent condition also. I used to explain in a multiple way, but anyways, even afterload will have a similar effect, because whenever you have a more load, when the ventricle contracts, because the afterload resistance is high, the ventricle bulges out and the ventricular wall and the septum tends to move apart from each other if the afterload is high. If the afterload is less, because the load is less, when the ventricle contracts, they can easily contract and the septum and the ventricular wall can come closer to each other. So you have to imagine this is like a more of a dynamic kind of a scenario. So it is absolutely preload dependent state. So what are the conditions that reduce the preload? Because of that, the murmur or obstruction will increase. So I can tell any drug that reduces the preload. Like for example, your nitrates. That's why amyl nitrate inhalation is a very important dynamic auscultation maneuver once upon a time. So nitrates can reduce the preload because they can increase obstruction and increase the murmur. And diuretic agents, AC inhibitors and angiotensin receptor blockers. All these things can reduce the preload and they can increase the murmur and obstruction. At the same time, there are other conditions that can reduce the preload, like for example, standing. Of course, it will cause pooling of the blood in the peripheries that can reduce the preload and increase the murmur. More importantly, there is a maneuver called squat to stand maneuver. This is a very, very important maneuver. So it can reduce the preload substantially and they can increase the murmur. And what else can reduce the preload? No, that's all. Valsalva. Next is Valsalva. Valsalva can reduce the preload because Valsalva, like increase intrathoracic pressure. We know that during the strain phase, the blood movement from the great veins will be very much restricted. So they can reduce the preload and they can increase the murmur as well. Apart from that, we have conditions that increase the preload that can reduce the murmur and obstruction, like squatting can increase the preload because when you squat, there are two events that are happening. One is the resistance in the peripheries will increase because you squat, and at the same time, you push that blood back into the heart so that your preload also will increase. So that's why squatting is a very powerful maneuver. Very powerful maneuver as far as HOCM is concerned because they can increase the preload also and they can increase the afterload also, thereby dramatically reducing the murmur. So that's why squatting is really, really important. Apart from that, lying down from standing position. So all these things can increase the murmur to a great extent. And conditions that increase the afterload, once again, squatting. Squatting is a very important condition that increases the afterload. And there is another entity that increases the afterload called isometric hand grip. That is because you are increasing the muscle contraction and peripheral resistance. Isometric hand grip, which can increase the afterload, thereby reducing the murmur. Conditions that reduce the afterload, once again, you need to know about the drugs that can reduce the afterload. Same drugs, nitrates, diuretics, and diuretics will not reduce, but ACE inhibitors and angiotensin receptor blockers can reduce the afterload. Because of that, you can result in increase in the murmur. So it's easy to understand. So first of all, you need to just take your hand and put the arrows. As I usually used to explain to my residents, one is when you stand up, especially from squatting, when you stand up, your murmur is going to definitely increase. Similarly, when you squat down, so when you're squatting, you go down, so murmur is going to decrease. Squat to stand, murmur will increase, and when you lie down, murmur will decrease again. So lying, murmur decreases, standing, murmur increases, squatting, murmur decreases, squatting to standing, murmur will increase. And at the same time, isometric hand grip, I generally think about doing a march past. I think most of the times your isometric hand grip will be done only when you're doing a march past, isn't it? So when you're doing a march past, your hands are down strictly. So I remember in isometric hand grip can cause reduction in the murmur. And at the same time, Valsalva, I equate it to Valhalla. Valhalla means heaven in Latin. So when you show heaven, you show up. So Valhalla, Valsalva means your murmur is going to increase. Valsalva, lying down, standing, squatting, squat to stand, lie down. So murmur is going to go in this particular direction. So it's just the hand notions that you're going to tell. Easily in exams you can answer. So where the murmur will go up and where the murmur will go down. And this is supposed to be extremely important for exams. Very, very important. Really. You should never confuse with this. Clear? So that's all. It's done. Then, you know the pulse, isn't it? We already talked about the pulse. Pulse, typically you will get a sort of a Bispherians pulse, or you get a sort of a jerky pulse, I told you, with equal peaks. That's classical HOCM pulse. You'll have a bifid pulse, 2 peaks in systole. That's very characteristic. We discussed already, so no need to discuss once again in the pulse. And as far as the diagnostic studies is concerned, I'm going to do ECG. in ECG, I can see LVH, severe left ventricular hypertrophy. Then I can see that septal hypertrophy in the form of pseudo-infarction pattern are very common. It's called a pseudo-infarction pattern. I told you already what do you mean by pseudo-infarction pattern. So you can see the pseudo-infarction pattern, especially deep septal cues, because the septum is very big here. They can produce deep septal cues in the lateral leads, V5, V6, 1 AVL and all. So that's called a pseudo-infarction pattern, which can be seen in ECG of a HOCM patient. Then echocardiogram. Echocardiogram, you can see the asymmetric septal hypertrophy. You can see the septal thickness. As I told you, you can see the posterior wall thickness. That's really important again to compare and see whether it's asymmetric septal hypertrophy or not. Then you can look for the dynamic LVOT obstruction. The best example of a dynamic LVOT obstruction is SAM of AML, that is systolic anterior motion of the anterior mitral leaflet. And you can look at for the MR jet that is happening due to the SAM of AML. And patients may have what is that? MR features also, like PSM, that's what I was about to tell. Pansystolic murmur also can be seen in HOCM patients. That is because of that SAM of AML. And so many things you are looking at, and you can see the left ventricular hypertrophy overall. And the LV cavity size is very important. And more importantly, I can look for the diastolic dysfunction. Diastolic dysfunction in echocardiogram. Especially, I look for something called E bar ratio. E bar E prime ratio. I mean, that's really not important for you because that's too much to find out diastolic dysfunction and all. So E bar E prime ratio I can look. Again, Kranti is asking most common arrhythmia and hypertrophic cardiomyopathy. Okay, again came back to the most common, AF. AF is the most common arrhythmia and hypertrophic cardiomyopathy. Happy? I mean, you would have expected ventricular tachyarrhythmias, but AF is supposed to be the most common arrhythmia and hypertrophic cardiomyopathy. Satisfied, Kranti? Because ultimately that comes to the common, isn't it? Most common once again. No matter how much ever you understand HCM, it distills to the common causes only. Most common. Okay. And in cardiac catheterization, you will see one interesting phenomenon. What is that? That's called a Brocken-Bro effect. That's also referred to as Brocken-Bro-Morrow-Braunwald effect. That's also referred to as Brocken-Bro-Morrow and Braunwald effect. That's otherwise referred to as Brocken-Bro effect. What you typically see in this Brocken-Bro phenomenon is quite cool. Remember, there is something called post-PVC potentiation. How to tell that? Usually, whenever there is more flow in a particular area, the events in that area will increase. Whenever there is reduced flow, events in that area will decrease. This is a very common notion that happens in majority of the pathology conditions in the heart. But you know, HOCM murmur and MVP murmur, that is mitral valve prolapse murmur, is going to defy this rule and defy this principle. And for example, HOCM murmur, whenever there is more flow, you're going to get reduced murmur. Whenever you have a reduced flow, you're going to get an increased murmur. So this is what is going to happen as far as the HOCM is concerned. Remember, it's opposite. I told you already. These are the only two conditions that violates the principle. And similarly, whenever there is more contractility, HOCM is going to suffer a lot because, as I told you, whenever there is too much of contraction, there will be obstruction of the LVOT. So too much contraction is also not required. So that is also one reason why among all the drugs, I told you so many drugs, but we didn't talk about digoxin. Digoxin is a drug that is actually contraindicated in HOCM. That is because of the too much contraction the digoxin causes. So whenever during the contraction, if the LV wall and the septum comes closer to each other, so they're going to produce more obstructions. That's why drugs causing too much of contractions also is going to be a little dangerous for HOCM patients. That is the reason why digoxin is contraindicated. Same thing happens. So first let us see. So this was first started with something called a de Carlos law. So can anyone tell what do you mean by de Carlos law? De Carlos law, same thing. De Carlos used the same principle. Whenever you increase the flow, events in that particular area will increase. So what they told is, we know that when I'm going to write, I'll be writing like this only, right? Which means during inspiration, your flow to the right side will increase flow towards the right side. That is the reason why there will be increased events on the right side, like TR murmur will increase. Originally, De Carlos described this rule with the tricuspid regurgitation murmur only. The TR murmur will increase. That is what we refer to as De Carlos law. Or on the other hand, anything on the right side will increase. But only one exception. What is that one exception? Everyone must be knowing, because whoever attended my class should be able to tell this. What is the only exception for the De Carlos law on the right side? Left side, there is no De Carlos law. De Carlos law is only for the right side. So whoever attended my class surely should be able to tell that is a pulmonary valvular click. Pulmonary valvular click that happens in valvular pulmonary stenosis. So pulmonary valvular click must be able to tell for sure. So where you're going to have a decreased pulmonary valvular click during inspiration, this is the only exception to the De Carlos law. Remaining, all the right side events will increase with inspiration. The most important example is the TR murmur. On the other hand, on the left side, you cannot call De Carlos law. Left side, there is no De Carlos law. Left side also, when you have a more flow, you should have more events, and when you have reduced flow, you should have reduced events. But as far as HOCM murmur and MBB murmur is concerned, it's going to behave oppositely. That more flow means less murmur, and less flow means more murmur. And this is the basis of this Brockenbrough effect also. It's going to be completely different, especially HOCM. And because now there are two events that cannot be differentiated based on this flow. So we need to differentiate these two events from each other, and need to have one concrete thing, on concrete maneuver to differentiate these two. So that is why this Brockenbrough effect came into existence, because it is positive only in HOCM patients and it is not positive in MVP patients. So what is that Brockenbrough effect? So let us see, let us see a normal patient who get PVC. Let us assume this is the premature ventricular contraction. Then you'll have a small pause, and don't ask what do you mean by compensatory pause, what do you mean by non-compensatory pause, which is beyond the head of you right now. So this is the PVC right now. So you get a premature ventricular contraction. So it is called premature ventricular contraction because it is premature. Because it is a premature ventricular contraction, you are going to have reduced filling during that time. And of course, the stroke volume is going to be low during that premature ventricular contraction. Suppose the next beat, when it comes, that is called a post-PVC beat. This is called a post-PVC beat. So this will have more filling because previously the heart has not filled properly. Now during this time, the heart has filled adequately and it has caused more filling. And compared to the previous beat by Frank-Starling law, because more filling is there, they have to produce more contraction. And more importantly, after post PVC, more than the filling, you should think about the ventricle itself will be contracting more because it's having more relaxation. And because students usually tend to confuse, I mean, this is for a UG level, I used to tell more filling is there, but more than the more filling, it is the more time that the ventricles are going to get. More time the ventricles get before they contract. So whenever they get more time, adequate time, so which means the diastolic relaxation also will be very nice. So that lucitropy will be good so that they can contract much better after some time. So that's why adrenergic drugs, if you take, they don't only augment the contraction, they also augment the lucitropy, which means they augment the relaxation also. That's really important once again. So it's not only for more filling, it's also about, more importantly, it is the more relaxation that you're getting here. More relaxation you're getting here. Because they are relaxing better and because they are filling better, this contraction will be powerful and you're getting more stroke volume. So I should not write more relaxation here, just to understand I told you. Here I can write, this will be the right place. More relaxation. And because of that, you get more powerful contraction and you will increase the stroke volume. So this will manifest as increased systolic blood pressure, decreased systolic blood pressure. And this will manifest as increased systolic blood pressure. And if you take the pulse pressure, that will basically increase because pulse pressure is a difference of systolic and diastolic we saw already. And here, if the SBP is low, the pulse pressure will be low. Here, if the SBP is high, the pulse pressure will be high. So there will be a substantial increase in the pulse pressure compared to the previous beat. This is a normal phenomenon. Now, what happens in HOCM patients is, HOCM patients, if you take a similar kind of a scenario, that is premature ventricular contraction and a post-PVC beat. In a post-PVC beat, because of augmented contraction, as I told you, actually the stroke volume will reduce and they will not increase. Since the stroke volume reduces because of good relaxation and more contraction, the LVOT obstruction will increase, because we saw already whenever there is augmented contraction, the LVOT obstruction will increase, and this decline in the stroke volume will reduce the blood pressure, and this will result in reduction in the pulse pressure. So this reduced pulse pressure that happens in the post-PVC beat is what we refer to as BBM. That is Brocken-Braunwald-Maurer effect. So, or simply called as Brocken-Bro effect. And this is a very important difference with that of the MVP versus HOCM. So in MVP, you don't see this Brocken-Bro effect. In HOCM, you can see this Brocken-Bro effect. So normally, in a normal patient, after the PVC, your SBP will increase and pulse pressure will increase. This is what we refer to as post-PVC potentiation. That's what we refer to as a post-PVC potentiation, where the next beat after the PVC will be more powerful. It's very simple, because ventricle is contracting more harder. But in the HOCM, that more harder contraction of the ventricle is going to be the problem, which is going to produce LVOT obstruction. And that's going to result in reduction in the pulse pressure, called as Brocken-Bro-Braunwald effect. And that is the most important thing that differentiates HOCM murmur from mitral valve prolapse murmur. And it is not seen in mitral valve prolapse, even though both have similar like dynamic auscultation results, but MVB murmur will not show the Brocken-Bro effect. Only HOCM murmur will show the Brocken-Bro effect. So this is what you see in the catheterization. And apart from that, you can use MRI also. MRI, typically you will be seeing late gadolinium enhancement especially in the mid-free wall of the ventricles. You will be able to see this late gadolinium enhancement, which indicates a scar that is not ischemic. That's supposed to be happening in HOCM itself. And genetic studies are rarely done. As far as treatment is concerned, there are many treatments are there. Most of the time, it will be a heart failure patient, especially with preserved ejection fraction. So this heart failure has to be treated very, very cautiously, because anything that increases the contraction can cause worsening of the obstruction. Like for example, inotropes, chronotropes, all these things has to be used extremely cautiously. Only in very, very limited and reserved scenarios only you should use this inotropes and chronotropes. And anything that increases contractility and increase the heart rate are very, very dangerous, because when you increase the heart rate, you're going to reduce the diastolic time. When you reduce the diastolic time, of course, you will reduce the filling. If you are going to reduce the filling, you're going to result in more LVOT obstruction, because of the more approximation of the septum and the ventricular wall closer to each other. So this is very dangerous. You should not try to increase the heart rate. At the same time, increasing contractility is also a problem here, because it's a very, very tricky scenario. So you have to use only selected drugs that can be used for heart failure. As far as I know, the most important drugs are beta blockers here, because they reduce the oxygen consumption of a hypertrophied ventricle. At the same time, they reduce the heart rate, thereby increasing diastolic time. Filling will be more, so that your LVOT obstruction will be less, so that the patients will fare better. And calcium channel blockers, especially verapamil and diltiazem, are also good in this scenario, even though I told you other heart failure, apart from HOCM, apart from this HCM, verapamil is not good in the sense like they don't affect survival. But in HOCM heart failure, verapamil is a good drug. And if the patient goes for arrhythmias, and one of the very important arrhythmia as far as HOCM is concerned is the atrial fibrillation and ventricular arrhythmias. In that setting, disopyramide as having a very good benefit. This is a very important point. Remember, amiodarone is not very good because it has multiple effects, but disopyramide is thought to have a very good role and have been studied extensively in many trials that it has a good mortality benefit as far as HOCM patients are concerned. So remember, diuretics, should be avoided as much as possible, but very carefully used. You cannot treat a heart failure without diuretics, but you have to be extremely careful. And vasodilators, you have to use extremely careful. Digoxin is something which has to be avoided. So diuretics can be used in congested states, but very, very careful. Once you reduce the preload, this disease is going to worsen. And vasodilators, definitely no. Digoxin, definitely no, as much as possible. And there are some interventions that can be done in HOCM patients. So one is for disease modification. That's called a disease modifying intervention. Second is to reduce mortality. To reduce mortality due to arrhythmias. Of course, you know, to reduce mortality due to arrhythmias, the only thing that you can do is ICD implantation. That is implantable cardioverter defibrillator implantation. That is the most important thing. And there are some indications for implantable cardioverter defibrillator in this thing. So the two most important things are family history of sudden death. Already some sibling would have died because of this, and you don't want to have one more death in the family. So any family history of death or sudden death or any death due to HOCM is definite indication of implantation of ICD. Any unexplained syncope, which means the patient has gone for VT/VF during the time of syncope, and next time the patient may not come with the syncope. Patient may actually die out of syncope before reaching the hospital. And remember, this HOCM usually happens around 30-35 years, very commonly. At age means I don't really understand. At any age you can insert. There has been evidences that around 2 years also there are certain infants also inserted with ICD. I really don't know. You're asking about age means I can't understand what type of age you are asking about, Naveen. Oh, you're asking about a patient who's having a family history and already known case of HOCM. So then you think about other possibilities. So family history of sudden death, definitely you have to insert. Then if the patient is having an unexplained syncope, then that means you have to definitely insert HOCM. I mean, insert an ICD, implantable cardioverter defibrillator. And then you have LVH, especially if the thickness is more than 3 centimeter, that is 30 millimeter. In that you have to definitely implant an ICD. And severe LVOT obstruction. Severe LVOT obstruction. This can be found out during exercise stress test. I can simply write as EST. Already I think we have discussed this point. In EST, if the BP does not rise by 20, so SBP rise by less than 20 millimeters of mercury during the exercise stress test, it indicates either a severe LV dysfunction, or in the setting of HOCM, it indicates severe LVOT obstruction, which means during exercise, the LVOT is going for dynamic obstruction. And probably in a patient who's having a extensive LG, extensive lead gadolinium enhancement in MRI. So these are the usual 5 indications. I believe in exams, usually the first 3 is what they're going to ask. Family history, unexplained syncope, and LVH more than or equal to 3 centimeter. So these are the 3 indications that they're going to ask, but the first 2 are the class 1 indications. Very, very important. Yeah, that is why I clarified that, because Alex is asking whenever there is more filling, you should have, like reduced more stroke volume only. No, not like that. But here I told you only for understanding there will be more filling for normal patients. But you're talking about more contractility. That's what you're talking about. Post PVC is a completely different entity. It's not only about the more filling, it's about the more contractility. So because the more contractility only, you are getting more stroke volume here. Or you can call it as reduced contractility. I mean, that's why it's a little difficult to explain. The phenomenon behind that is not only the filling, the phenomenon behind that is basically the lusitropia also. If you have a poorly relaxed ventricle, you're going to result in poor contraction. A good relaxed ventricle is going to produce good contraction. So more contraction is what the problem here is, more than the filling. So fall in SBP is, yes, if the stroke volume falls, of course, SBP is going to fall. I mean, to explain this normal post-PVC potentiation, it's a normal thing to explain about the filling, but it's not really the filling, that's the contraction that matters really in the post-PVC beat. And there are some disease-modifying interventions are there. Like, for example, you have two procedures. One is called a surgical myomectomy, and second is called septal alcohol ablation. Commonly preferred is the myomectomy. This is what is preferred basically compared to that of the alcohol ablation. Alcohol ablation is done only for frail patients. EST is exercise stress test. We discussed yesterday how much we have discussed about EST yesterday. So many points I have told you. Exercise stress test. I think we have discussed already. Clear? Yes, I told you. SBP increased by less than 20, which means SBP should rise by more than 20 and it should reach more than 120 millimeters of mercury. If the systolic blood pressure fails to rise by 20 millimeters of mercury also, then it indicates a severe LVOT obstruction, or in other context of ischemic heart disease indicates a severe LV dysfunction. That's all. Basically, endocardial prophylaxis is not recommended. Suppose if they ask IE prophylaxis needed or not, previously it was recommended, currently it is not recommended. In 2007 guidelines, it was recommended. In 2013 guidelines, it's clear they have removed the IE prophylaxis from the guidelines. There is no indication for IE prophylaxis as of now. And the patient should be counseled not to participate in any kind of competitive activity, competitive sports. They should completely differ. Two diseases, one is ARVD, definitely, and second is HOCM. Both these patients should not participate in any competitive sports. I think one English cricketer who suffered from ARVD retired in 2015 after the World Cup. Everyone knows him, obviously. Yes. He's an English cricketer who retired in 2015. He scored a century in the first match of 2015 inaugural World Cup. Inaugural match of the World Cup 2015. He took a century in the losing cause, but people are telling Andrew Strauss and Lester Cook. I think they'll be scared. James Taylor, correct. His name is James Taylor. He retired from international cricket at 27 years of age itself because he had ARVD. And he got a syncope during the ARVD. We discussed already, man. What more you need about ARVD? Like, more than the triangle of dysplasia and the Naxos disease. Anyway, I too love cricket or not. I love cricket. Why? Because I love two sports, table tennis and cricket. Because I was once upon a time a player in Ranji Trophy. I played for Railways team in 2002 to 2004. I played for Railways team. So during that, before that also, I have a lot of passion towards cricket. And I was a state level player of table tennis also. And why I concentrate on cricket and table tennis is a different story, because I didn't get good grades in school. That's the main reason, because I suffered from severe attention deficit hyperkinetic disorder. So because I had severe ADHD, I had a dyslexia also, so I couldn't speak properly. Later on, I went for speech training for 1 year. And because I went for speech training, I couldn't pursue with my studies for a year or maybe year and a half. Then I was a dropout during my 7th standard or 8th standard, I think around. So after that dropout, I couldn't really concentrate much on the studies. So during that 1 year when I was going for speech therapy, I started developing skills on cricket and table tennis. But that's why whenever you like something, sometimes life ruthlessly takes something out of you. So I didn't know that I had a congenital condition called patella alta. Later on, I came to know when I entered my IIT Roorkee only. Because when I got recurrent patellar dislocations, I got some 8 to 10 patellar dislocations in a span of 3-4 months. When I entered the Ranji Trophy, that's like a huge hit on the back of the head, because when you think this is going to be your passion and this is what you're going to enter, suddenly you get this kind of bad news that you cannot play any competitive sports hereafter. And they told, like, if you keep playing competitive sports, there will be a severe osteoarthritis of the knee, and your patella should have been removed, and you'll go for a patellectomy, and your terminal 15 degree of extension will not be possible. That's what the orthopedician told me. Either you stop the competitive sports or lose the patella. And after so much of struggle, so much of problems, and I know I couldn't recover from that basically, because that's the reason why I don't want to really pursue the studies that much. But somehow, because I lost my father when I was 7 years of age, I was the only son for my mother. So there's no other option. I have to listen to my mother also. So she told, like, do something useful to the society, like by being a doctor. So that time, okay, I felt okay. Maybe I couldn't think of anything because my mind is completely blocked, so that I can at least listen to my mother for one time. So I took medicine after that, after entering IIT Roorkee. I mean, the reason why I took IIT Roorkee was completely different, because my maths teacher told, when I was having dyslexia in 7th standard and 8th standard, my class teacher was mathematics teacher, and he told, like, you will not be able to crack maths. And he called me and my mother to the headmistress, and he told, like, please send them to a different school, because this guy is not fit to be in the school because he cannot study. That's what he exactly told to my mother in front of me. My mother was telling, actually, no, sir, he's actually going for speech therapy. In 1 year or maybe 6 months, he will get better, of course. But the problem is, like, we don't know when that will happen. So my headmistress also told, look, he's coming always around 35th grade in the class, and out of 40 students, and we cannot take this kind of children, and is very non-attentive in the class. So get it better and come back. So we went for 1 year and came back. During that time, I learned something, all right. But purposefully, I didn't go to that school. I went to a different school. I mean, to be honest, a government school. That's where I studied in Tamil medium, because I don't want to go to the school again because they insulted me. Then purposefully, I worked hard a little bit, maybe 1.5 to 2 years. I worked hard because I had some kind of like fire that I need to prove them wrong. That they told I won't get mathematics, I won't be able to crack mathematics. So I used to study mathematics and physics so much more than chemistry and biology. So ultimately, I got the first rank in the state after the 12th standard, where they used to keep that entrance exam after 12th. We got this that TNEEE, isn't it? Tamil Nadu Engineering Entrance Examination during that days in 2003, 4 and all. So I become the first topper in mathematics. I got 50 out of 50. Then I entered IIT Roorkee by cracking IIT JEE also. Then after that, then again, I couldn't play, because after IIT, my main thing was to play for the state and country. But that didn't happen really, because I need to get back. So my mother told, it's okay, you cannot stay separately. I didn't know Hindi that much. So you stay back in Chennai or maybe anywhere in Tamil Nadu, so that we'll be together. So my mother accompanied me. We together stayed in Chennai, and I completed my MBBS. During my MBBS, the struggle was very real, because I studied in a Tamil medium, and all the books were very voluminous, and I lost interest in studies, because all over my days I've been concentrating only on cricket, to some extent on table tennis, and I've been studying in Tamil medium and mathematics, of course. And suddenly going into a completely different field on biology meant a complete U-turn for me. My life is a full circle, where I got really, really depressed, and I didn't study that much during my first year MBBS, where somehow I scraped through, because one of my best friend's mother was sitting as HOD in biochemistry and all. So maybe through her influence, I got through somehow. But second year was very bad. I got bashed in forensic medicine. I got failed. Then I rewrote again. Then in ENT again, I got bashed. I got failed in ENT again, because of that instrument section was very bad. Then again, because all these 3 years I was struggling a lot, then I thought I'll discontinue and do something else. Then, of course, again, my mother came and he told, like, it's better, like, when you are able to crack mathematics, which was completely difficult for everyone, then why can't you crack this one, which is just based on memory and some certain facts? Why can't you do that? That's what she told. So again, final year was something which was a turning point for me. So where I started reading, and somehow I scraped through, no issue. So after that, the reason why I started teaching is different, because there are some friends of mine. I mean, they are very good people. I'm not telling they're not good people. Maybe I am not a very good, like, fast learner. I don't read anything fast. So teaching me something is little difficult by someone. So whenever I go ask for help, or whenever they are studying, when I go there, they purposely tend to change the topic. Why they tend to change the topic is because I am a very slow learner. I will ask 2-3 times the same thing again and again. So they tend to change the topic and they don't read. So that is the time I realized that I wanted to read myself. I don't want anyone's help. I realized that over time, and I thought like I'll start teaching others, so that people who believe that I cannot learn things should see that I teach someone else. And that happened, of course, and that's the reason why I started teaching into 2015. Or I mean, I used to teach from my post-graduation time itself in 2012, 2013 itself. But anyways, that progressed and I started teaching over a period of time. And somehow it worked. And this is my life story in a short span. And he's asking about love story. Okay, that's not something to be taught about. So you came to study, not to get about love story. And I have a lot of problems, like even love was not fair for me, to be honest. So I don't want to tell that, of course. So there's nothing else to tell really. My PG preparation. I did attend some speed classes. There is an institute called Speed. I don't know how many of you know. I did attend my speed classes. Speed classes, that time I used to attend that free classes only because I didn't have that much money during that time, especially during my internship. So I don't used to attend classes that much. I gave, there is Bhatia test series will be there during those days. So test series I attended, and only speed classes, only free classes if they keep, I'll attend. And Vinayak Sandil sir helped me a lot during that time. So I discussed with him. So some classes, if I feel some subjects are difficult, I used to attend those classes. Apart from that, I didn't do anything much. And during that time, I worked in CMC Vellore also as the casualty medical officer. Then I worked in orthopedics department for some time immediately after my internship. Then that JIPMER exam came, and I took pathology in JIPMER. I think many people know that. I did pathology for almost 8 months in JIPMER. Then during the time of pathology, that is immediately after internship, but the rank was not good enough to get a medicine seat. My rank was around 97, I think, in JIPMER during that time. So I didn't get, even AIMS rank was not that good, around 32, 35, which is not good enough to get a medicine seat. And USMLE, I completed the step 1 in, I think, when I was a final year beginning. I mean, in the end of the pre-final year, when I go into the final year beginning, I finished step 1. Step 2, I completed during my internship. But later on, again, there was a lot of issues with regards to go to US. I believe in certain things. But one of my popular beliefs is I should not leave my mother, because my mother is alone and she spent all over my life only for my life and nobody else. And when I go to US selfishly, like that doesn't give any, that's very unfair on her. So, and she's having a lot of health related issues also, and I can't take her, of course, everyone knows that. And there's nobody who can take care of her as well. So that will be very selfish on my part. So that's why I denied giving the clinical examination. I mean, the one thing I don't regret is that I don't have any much interest in going to US, just because people were telling I started preparing for AMLE. Why did you drop pathology in JIPMER? That is because I wanted medicine. Basically speaking, I wanted either medicine or orthopedics. To be honest, that's an extreme kind of a scenario. Everyone asks me why you want medicine or orthopedics. Both are completely opposite. Everyone tells medicine, pediatrics, or anesthesia, or surgery, or orthopedics, but you are choosing medicine, orthopedics because I like it. That's all. Who cares? I like these two subjects. So that's what I wanted, either medicine or orthopedics. Later on, I decided, because of my knee issues and because of my health issues that were there during that point of time, my mother advised not to be too much stressed by taking surgery or orthopedics, because I cannot stand, of course, for a long period of time. And of course, I have some, I had a SVT also. It's an AVNRT. And I had some 2-3 aberrant tracks where I underwent RFA. Now I'm fine, no issues. But during those days, it was little scary for my mother also. So after RFA, I was much better. So my mother don't want me to take orthopedics, so that's why I took medicine and took medical college. Yes, Kilpak Medical College, that's where I studied. And again, many people started telling that I got a NEET rank of 179. And I mean, that time I was working in JIPMER, and I didn't expect that rank, because when I was working in JIPMER as a pathology fellow, I used to really enjoy a lot. I'm not a really, I might look serious right now, but I'm not a really that much serious guy, to be honest, because there are a lot of things which was serious in my life, and there is what is the point in becoming serious for small things? So I hate being serious. So I used to play a lot. I used to sit in front of the ladies hostel for a lot of time, because JIPMER is one place where you need to sit in front of the ladies hostel. So I didn't study that much. So that NEET rank was very surprising for me, that 179. But I didn't deserve, to be honest, because I didn't really study that much. But somehow I got through. But there are two reasons why I choose KMC. One reason is because I really didn't deserve to be in the higher colleges, but that was already there in my mind. And second thing is, I wanted to do in my parent college, and a lot of other reasons were there, where I can work nearby hospitals, because KMC has a lesser caseload compared to Madras Medical College. And I really don't want to go out of Tamil Nadu, because I'm scared, because I don't know Hindi. And I always believe that whenever you speak to the patients, you should speak in the native language, so that you understand their concern. So you will understand things much better. The history taking and all will be much better. So I wanted to be in Tamil Nadu. And that's not, and many people even think that I'm kind of this thing, Tamil freak. No, not like that, because I didn't know. That's all, as simple as that. I've tried learning Hindi. Even my wife has tried teaching me Hindi a lot, but I couldn't. Really, I'm so bad at it, especially very difficult. I tried learning some 2, 5, 10 words I know, which I can manage when I come to North, but it's not efficient to take a history and all properly. Why didn't you opt for a DM? That's because again, I decide what I want. Basically, I got NEET SS rank 2 in 2016, I guess, where I took in Jayadeva, I think. Jayadeva Cardiology. I was there for 20 days and I discontinued because I didn't like. Then after that, 2017, I took in Chitrai Tirunal Institute in Kerala, where again, I didn't like. I discontinued within a month because I felt like cardiology is good, but later on I felt like it's not very good. Then in 2017, at the same time, I got rank 1 in NIMANS also. But again, I went there, I didn't like because of a lot of reasons. Then later on, I thought like, let me be a physician. So who cares? It's all up to me. So when I like it. So I always believe when you're ready for something, you do it. When you're not ready for something, don't do it. As simple as that. I'm always an ardent believer of that. I believe that I am not ready right now to become a super specialist. In the sense like, I like what I'm doing right now. When I stop liking what I'm doing right now, maybe teaching or maybe practicing, that time I'll decide that I'll do DM. So age is not a bar, like as far as you're living, whether you're living happily or not is what matters. How much you're earning, I don't think it really matters. What others think about you, again, it really doesn't matter. If your internal side is happy, and that's what matters for every human being when you take in the deep run. So that's what I believe. So I don't really care about what others say. I don't really care about what others say about my degree. I don't care about what other person got a degree. Or that is the reason why I don't really mention any success or failure in any social media. Because social media, I don't think it's a Facebook. It's actually a fake book where people only post very good things about them. They don't post bad things about them. And during my pre-final year, basically, I got failed in my ENT exam, isn't it? That time I posted that I got failed in ENT exam. Like that's correct, isn't it? Because when I get a medal, I post. When I get a fail, I don't really post, isn't it? What is the point there? You need not be only a critic. You should be. Instrument is asking what instrument you failed. Let's say Lichwich, trocar and cannula. That is for sinusitis instrument, I think. Lichwich, trocar and cannula. That I didn't identify, and my HOD failed. And that's not the reason why I failed in ENT. That there are a lot of other reasons why I failed in ENT. because me and my friend used to be very, playful in the OTs and all. So they used to surgery. So that time my friend got, I think, the new N73 phone. I think you remember N73, right? So that is the first time that sliding kind of a phone will come, N73. My close friend got that N73 phone. I can imagine only in my dreams. So I want to just see what's happening. So they're opening and searching. And we are seeing something, we're playing some game. And after finishing the OT surgery, my ENT HOD is coming and watching us for the last 2 minutes in the corner of the OT. So probably that is one reason why we both failed, basically. We both didn't pass through. But anyways, fine. So that's a funny side. And I really don't care, this is not a failure at all. Because now current crop of students, that's why, failure and success should be taken in an equal proportion, basically, according to me. One failure doesn't mean that you're bad. And most of the time we feel bad only because what others will think. We feel bad only because others have gone through. So when you lose those two things, what others will feel, you don't care. You're not going to take failure into your heart. And at the same time, you don't, if he gets successful, he's going to earn. Is he going to give 1 lakh rupee or 2 lakh rupee to you? And that doesn't really matter. It's not fair enough to ask him also when you're in a difficult situation. It's about your sustenance, your help. So I always tell why you read. Why you want to read. You read for yourself. For example, if you know something today, which means you have that happiness. So yes, I know this thing. So I learned this better. Tomorrow I will be a much better person because you know some extra knowledge. So this life is uncertain. And in that, if you learn something, that is for your improvement. That's all. You don't know what's going to happen tomorrow. So today I learned something because tomorrow I can do something in the expectation that I can do some good for the community and good things for the society. So why you want to really compare with yourself with others? Everyone is unique, whether you fail or whether you pass or whether you get through or whether you not get through, doesn't matter. So you be yourself, and you be an asshole for someone, doesn't matter. You be a good person for someone, doesn't matter. But if you feel what you're doing is good, that's more than enough. That is all. That's all life is all about. I lead a very good life, very happy life, and that's it. Nothing more than, I don't like, people tell this inspirational, but I don't really have any motivational speech according to me. In the sense, I cannot really tell you can do it, you can do it. There are so many people, for example, right now, how many people are there? I don't know. But I think 107 participants are there right now. I cannot tell all 107 participants are going to crack rank 1 if I tell I'm the biggest fool in the world. But that's what the world is doing right now. They're making you falsely believe that you will succeed. So which coaching center or which person is going to tell that fail? It doesn't matter. I will tell. You can fail. It doesn't matter. Ultimately, it breaks down to only one thing: how much mental peace you're having and how much satisfaction you're having. If that is the one that you're going to get, that's all. Nothing else you need in your life, according to me. And if degrees are the ones which are going to bring you success, if degrees are the ones you think it's successful, then why an AIMS candidate has to suicide? If you think your money is going to be successful, maybe leave SSR, but why big shots are suiciding now? So it's simple, these things are not going to equate into your happiness over a period of time. So ultimately, you need to remember one thing, that you should learn yourself to be happy. That's the most important thing. No matter whether you have money or not, no matter whether you have Mercedes-Benz or not, doesn't matter. You need to know how to be happy. The current generation is completely spoiled by showing examples of others and showing examples of everyone around them, to tell that compare, and you have to be like him, you have to get first rank. They're all making you enter into a rat race. So that's really, really bad. And at least your future generation, your progenies, your children, at least teach them to be happy rather than teaching them to be successful. Really, ultimately, you have to be happy. That's all. No matter what. That is the most important thing. No matter you may be a beggar, it doesn't matter, but you have to be happy. That's all. Last question: why did you left NIMANS? Because I really didn't to work. What I expected is different, and what I saw there is different. So I don't want to really compare and tell. And maybe people might be liking NIMANS, so I don't want to completely break that trust. So I didn't basically like. That's all. You got, yes, rank 1. Okay. So then let us go back and discuss on what we have left, because we have discussed about my life story a lot, which may be useful for someone, which may not be useful for someone. But how is medicine as a branch from your perspective? It's a very good branch. And again, you should not think about money whenever you choose a branch. It's all about, see, currently everyone talks about scope. It's not scope. What is scope? What is scope? Scope is nothing but money. That's what you're asking. Medicine is a branch that has money. I'm not telling no. But if you think and take some field as a money-making field, and you're definitely going to get disappointed if you're not going to make money. Take a field as if you're going to do something in that field, definitely you will like it. So that's the one thing I want to tell. Society treating doctors very badly, it is very discouraging from your thoughts. Actually not. To be honest, what I have seen from my perspective is there are very few people who think bad about this, or bad about the doctors, and there are still a lot of people who are trusting doctors and who are actually, respecting doctors a lot. So think only about the people who respect you. Why you want to only think about these negativities? This minor part of people will always be there who's going to dislike you, and there's no point in thinking about them. And even in the past, the respect is actually a fake respect only. People who wanted to respect you truly will respect you no matter what you as a person. So don't care about the people who don't respect you, and be safe also. I'm not telling don't be safe, and be honest, and be a person who's going to justify the profession, and that's more than enough. What others think is not our problem at all. And there are people who doesn't like me also, but I don't really care. I only want to do good. What I feel is good, I will be doing. I'll have to do justice for my profession. I want to do the justice for what I'm doing right now. That's more than enough. So I get a very less salary in medicine, but still I'm very happy. I'm not really into more money. After I forgot stuff in the sense I'm not able to diagnose and remember anything. Will it change when I start practicing? Of course, yes. See, remember, medicine is something which you can remember only if you start practicing. If you don't study anything, you cannot really practice anything. That's very important point to understand. So it is a two-way process. You read something, you go and try to diagnose, you will not be able to diagnose, you come back and read, and now you make a diagnosis. Okay, fine. So this is what is given in the textbook. And when you see something and again you go back and see the patient. So this is like a two-way process. So it's not like a one-way process. Everything has that sort of an experience. That's all. Naveen is telling he likes pulmonary medicine, very good field. If you want, you can take, has a very good scope, because pulmonary medicine people can manage the critical care also. And we need critical care people, because anesthetists are the ones who are managing critical care right now. And remember, it's because they handle the Boyle's apparatus, we are giving critical care to them. But I believe that there should be more critical care specialists. So pulmonary medicine is the way to become a critical care specialist. And we need, yes, you are welcome. So it's a very good branch if you want to do a critical care. But apart from that, if you are just restricting yourself to a bronchoscopy, maybe, that's not a very good option. If you're doing critical care, then that's fine. Endocrine is also a very good branch, whatever. And Riju is only a third year now. So telling right now what branch you like is not good. First of all, to do endocrine, you have to do medicine first. So we decide whether Riju has to do medicine or Riju has to do surgery first, which itself is a huge change in the process. Once you choose that, then you come back. I've seen a lot of people who change the branch. I think Riju will be one of those. So a lot of people in the sense like they'll be telling that, sir, my dream is surgery. I want to take only surgery. Like they will get, not fortunately, I'm very unfortunate for those guys, because they get rank 5. It's very unfortunate rank, because these guys, after getting rank 5, they'll be brainwashed to take radiology. They will end up in a radiology and inside the dark room. So I'm not telling radiology is a bad branch, but unless and until you like something, why you want to change your profession unnecessarily? You like something, you do it. Don't do just for the sake of money. That's what I'm trying to tell. Ultimately, finally, I've seen a lot of radiologists who are extremely depressed because they live in the dark room. They don't see patients, and especially during the COVID times, they are struggling a lot to read the CT. So much load is there. It's not like radiology is a easy field or a, like your evergreen field, like what you think. Every field has a struggle. Every field has a struggle to make money. Every field has competition. And with the number of doctors that are coming inside right now, you are going to face a huge struggle in the community and the society. So, I mean, it means the only way to get out of all these things is to keep yourself happy and to enjoy whatever you do. That is the only way to fight this depression and fight this kind of struggle. Otherwise, it is impossible in the future to be without depression. Very, very, very difficult. So it's going to be a pandemic. Later on, it's going to be really, really bad. And your date of birth, I cannot tell the year. I don't want to. Yes, Gautam told already it's 26 September. I don't tell the year. So it's 26 September is my date of birth, but I don't really care what day I was born. Okay, fine. So let us go back. And Arshad is also 26 September. Congrats. You're also number 8. And my mother used to tell number 8 used to struggle a lot, but ultimately God will be with them. But I don't believe in God, but my mother used to tell that. Okay. Thank you, Shabnam. Okay, so we have discussed about the hypertrophic cardiomyopathy, but we have not yet, we have wasted quite a lot of time. I think some around 20 minutes is waste now. So let us go and try to discuss on the restrictive cardiomyopathy. So where is that RCM? Restrictive cardiomyopathy, RCM. So, thank you, Riju. And as far as the restrictive cardiomyopathy is concerned, you don't know whether it's a systolic or diastolic dysfunction. In fact, most of the patients will have systolic as well as diastolic dysfunction as far as restrictive cardiomyopathy is concerned. Remember the fact that hypertrophic cardiomyopathy commonly produces diastolic dysfunction, whereas dilated cardiomyopathy produces systolic dysfunction, whereas RCM is going to produce both systolic as well as diastolic dysfunction. And usually, as far as RCM is concerned, the most important problem is the diastolic dysfunction. That's going to be the most problem. That is the impaired ventricular filling. Impaired ventricular filling. And this happens in the setting of a non-dilated ventricle. And this happens in the setting of a non-hypertrophied ventricle as well. Non-hypertrophied ventricle. This is the exact definition of an RCM. So in the sense, they will be usually having a normal or only a mild decrease in the ejection fraction, which means there is no prominent systolic dysfunction. So the diastolic dysfunction will be prominent in a patient with an restrictive cardiomyopathy, where there will be impaired ventricular filling. And that should happen in the setting of a non-dilated and a non-hypertrophied ventricle. That's all. This is very, very important because RCM is going to happen very commonly in the setting of an infiltrative disorder. That's where you're going to get RCM. Very, very important point. Remember, non-dilated, non-hypertrophic, and non-ischemic as well. This diastolic dysfunction should not be due to ischemia. There can be some element of systolic dysfunction that is not prominent. Diastolic dysfunction is going to be the prominent one. That is evidenced by having a normal or a only mildly reduced ejection fraction. That will result in impaired ventricular filling. And the ventricle should be non-dilated and non-hypertrophic. These are the conditions to diagnose the patient as a restrictive cardiomyopathy. I can divide the cause of restrictive cardiomyopathy into myocardial process versus an endomyocardial process. So first, let us see the myocardial process that will involve only the myocardium, or there can be some conditions which rarely cause endomyocardial involvement, which means they involve the endocardium as well as the myocardium, endomyocardial process. So as far as the myocardial process concerned, my CTDs are very important, coronary disorders. Remember, CTDs can produce both the dilated cardiomyopathy as well as restrictive cardiomyopathy, but there are some CTDs which typically cause restrictive cardiomyopathy more than dilated cardiomyopathy, like systemic sclerosis and idiopathic inflammatory myositis. Systemic sclerosis, scleroderma, especially diffuse variety of scleroderma, which we'll be discussing subsequently. Then we have idiopathic inflammatory myositis, IIM. Both these disorders can produce myocardial involvement and then produce restrictive cardiomyopathy. And there are some conditions that infiltrate the myocardium. Whenever I talk about infiltration, the first condition I'm going to talk about is amyloidosis. Amyloidosis is the first condition I'm going to talk about in this particular scenario. So what are the types of amyloid that can produce cardiac issues is the question here. So remember, AL type of amyloid can produce. This is called a primary amyloidosis. Then AA type of amyloid can produce, but rare. But it can happen in the setting of familial Mediterranean syndrome. You'll be knowing, isn't it? Mediterranean fever. I think I have told wrongly. You have familial Mediterranean fever, FMF, very commonly in FMF, the usual cause of death is the cardiomyopathy and arrhythmias only. So that's why they die. So it can happen in AA, but rare, but very common in the setting of familial Mediterranean fever. And it can happen in the setting of TTR-related amyloidosis. We'll be discussing more about that in rheumatology section, where you have this transthyretin-related amyloidosis. TTR-related amyloidosis usually produces this cardiac involvement very commonly. It could be wild type, that is completely different. Otherwise, you have something called a senile amyloidosis that is also due to transthyretin related only. So these are the three characteristic types of amyloid that generally produces cardiac involvement. Remember, there are multiple other types of amyloidosis also, but these are the three basic types of amyloidosis, basic forms of amyloid that is going to have cardiac involvement, transthyretin related. And as far as the amyloidosis is concerned, ECG will be very typical. Whatever we have studied, it will be extremely typical. They will be having low voltage complexes. Very classic, whatever we discussed till now. So low voltage complexes. Then you can have something called a pseudo-infarction pattern, where you can have a prominent septal queue, pseudo-infarction pattern in many leads. And they can have conduction blocks and like bundle branch block, fascicular blocks, they can get conduction blocks. And ultimately, they can culminate in development of ventricular arrhythmias, which is also a very important cause of death. And if they ask you what is the most common cause of death in AL amyloidosis, cardiac cause. If they ask what's the most common cause of death in TTR amyloidosis, again cardiac cause. If they ask about what is the most common cause of death in familial Mediterranean fever due to AA amyloid, it's again cardiac only. Okay. Riju is asking in chronic diseases, it is ATTR. No. TTR produces two things. One is called a senile systemic amyloidosis, that is SSA, then called a familial amyloidosis there, that is familial FA, familial amyloidosis. So that is only related to TTR. A will be the one that is seen in chronic inflammatory conditions. So because there is something called a serum amyloid A protein, that will be increased. That's like an inflammatory, acute phase reactant. The serum amyloid A protein will be increased only in chronic inflammation. And this is the one that is going to produce this AA type of amyloid. So in chronic inflammation, you will get AA type of amyloid only. You will not get ATTR. ATTR will happen in two conditions. One is senile systemic amyloidosis, and second one is your familial amyloidosis. Two conditions. And all these three can cause cardiac involvement. But remember, AA more causes nephrotic syndrome. I'll come back to that. But familial Mediterranean fever is one type of AA amyloidosis, which commonly produces cardiac involvement. In all these three conditions, in any time, in exam, if they ask you most common cause of death in amyloidosis, your answer must be cardiac involvement. That is the usual cause of death. And these are the usual ECG findings. And as far as the echo findings is concerned, this is very kind of a sparkling finding. So that's what is going to be found in echo. That's a sparkling appearance. That's like a dot kind of a sparkles you will see in the echocardiogram. And remember, even though the ventricle will not be hypertrophied, remember there is a difference between ventricular hypertrophy and ventricular thickening. So ventricular thickening may be seen a little bit. Remember, it's non-hypertrophic. I'm not telling hypertrophy. There will be a small amount of ventricular thickening will be there. Hypertrophy is different from thickening. And the echogenicity in echocardiogram will be completely different in hypertrophy and completely different in a simple thickening. It will be a ventricular thickening with a different echogenicity, so it's not hypertrophy. And whenever you see this kind of a thickened ventricle with a low voltage complex, that's a paradox. That in exam always suggests a restrictive cardiomyopathy. Because usually whenever the ventricle is thickened, if you think it's hypertrophy, there should be bigger QRS complexes. But in restrictive cardiomyopathy, you have a thickening of the ventricle, but that shows low voltage complexes, means it's a paradox, isn't it? So in that setting, you can diagnose a probable restrictive cardiomyopathy. And very commonly, you will have this biatrial enlargement, which is very characteristic of restrictive cardiomyopathy and amyloidosis especially. Both the atrials will be enlarged and valve thickening will be there. Clear? Valve thickening will be there. And the patients will be having a normal septal thickness also. Septum will not be thickened. Why I'm telling that point is because that goes towards an HCM if the septum is thickened. So even though the ventricular thickening is there, septum will be normal. Septum will not be thickened. Clear. So these are the findings of amyloidosis in echocardiogram. And of course, MRI can show that characteristic late gadolinium enhancement in a distinctive pattern. Many times in amyloidosis, you'll be seeing a speckles of late gadolinium enhancement or a concentric subendocardial gadolinium enhancement. So these are the two types of enhancement pattern that you can see in MRI, which can suggest that the patient is probably having amyloidosis. Remember, if they ask you the most common cause of respiratory cardiomyopathy in the world, I'll go for amyloidosis. Amyloidosis is going to be the most common cause of RCM, infiltrative RCM in the world. Then apart from infiltrative causes, we have third condition, that is sarcoidosis can produce. Sarcoidosis with cardiac involvement will happen generally in systemic and diffuse sarcoidosis. We have something called an acute and a chronic sarcoidosis. Usually organ involvement is very common in chronic sarcoidosis. Acute sarcoidosis has an excellent prognosis. Usually it will not involve it will not cause cardiac involvement. Usually one of the important examples of acute sarcoidosis is Lofgren syndrome, arthritis, erythema nodosum, and you have, what is that? What is the third thing? Lofgren syndrome. Anyone, if you remember, you can tell. Arthritis, erythema nodosum, and lymphadenopathy, bilateral hilar lymphadenopathy. Yes. So if you have these three things, this is Lofgren syndrome. You would have remembered, isn't it? Acute sarcoidosis. That has an excellent prognosis. But as far as chronic sarcoidosis is concerned, it's a problem. It's going to involve multiple organs, and it's not a good sign. And number 4, you can get this in the setting of a hereditary hemochromatosis. I told you hemochromatosis can produce DCM, HCM as well as RCM. So, but we generally think about RCM. RCM is where I want to tell hemochromatosis. Then storage disorders. Storage disorders like Gaucher's disease, Pompey's disease, Fabry's disease. All these things, storage disorders, can produce RCM also. Then diabetes also can produce respiratory cardiomyopathy. Fine. And you have endomyocardial process, which can affect both the endocardium as well as the myocardium. So the most important is the chronic eosinophilic syndromes, typically Loeffler syndrome. Loeffler syndrome. And you have something called endomyocardial fibrosis, that is called EMF. That is because of fibrosis of the endomyocardial area. Then radiation, that is really, really important. Radiotherapy can produce respiratory cardiomyopathy. Remember, this is one condition which can produce both constrictive pericarditis as well as respiratory cardiomyopathy, which is going to be extremely important for exams, because radiotherapy can produce both. We have a whole lot of echo training to differentiate between constrictive pericarditis and respiratory cardiomyopathy, because both have very similar findings in most situations. But radiotherapy confuses you much better by causing both constrictive pericarditis versus respiratory cardiomyopathy. And they tend to occlude the ostium, especially they can develop LAD stenosis, which can be a feature of radiotherapy also, especially ostial LAD, proximal LAD. Very proximal LAD stenosis is also a very common entity with radiotherapy. Especially if they ask you about radiotherapy related cardiac disease, go for CP plus RCM. Both can be seen in radiotherapy. And ostial LAD stenosis is also extremely common in the setting of radiotherapy. And there are some serotonin related serotonergic conditions which can produce this kind of endomyocardial fibrosis. What are the serotonergic conditions? First, I will think about carcinoid. Carcinoid is a very important thing which can produce fibrosis because of high serotonin. Then serotonin agonists can produce, like methysergate. Then we have ergot compounds, ergot alkaloids can produce, very rarely, metastatic cancers. Finally, I can write, can produce respiratory cardiomyopathy. Metastatic cancers. So fine. So of course, you have multiple causes. Among all these causes, amyloidosis is going to be the most important of all. So especially that characteristic findings of low voltage complexes, sparkling appearance in echocardiogram. These are very, very common questions and multiple times asked questions as far as exams are concerned. So very difficult to treat. Respiratory cardiomyopathy, it's not easy to treat at all. Because again, you're going to treat like your same, heart failure only. So whether the patient is having heart failure or not is the question. So how you're going to treat this, you're going to treat how you're going to treat other heart failure only. But they can have preserved ejection fraction, so it becomes even more difficult to use liberal diuresis. So diuresis has to be little less because they are preserved ejection fraction. You should not try to reduce the volume so much. And there is a lot of challenges in treating the restrictive cardiomyopathy, which I don't want to really talk much about. So very difficult to treat. And one of the most worst prognosis of all the cardiomyopathy is going to be the restrictive cardiomyopathy only. Even certain diseases are contraindications for transplant as well. I think this is all about cardiomyopathies. I think, of course, the hypertrophic cardiomyopathy is going to be the most important of all. We have discussed in detail all this stuff. I think this must be useful. Indra is asking for a break, but I think we can finish one more topic before that. 7 o'clock, I'll give you a break. Before that, I wanted to complete my discussion on shock. I mean, this is a bridging process. Shock can be discussed anywhere. You can discuss in nephro, you can discuss in endocrine, you can discuss in respiratory, you can discuss in infectious disease, you can discuss in cardiology. This is a common topic. First of all, what do you mean by shock? Shock is basically reduced perfusion to organs. But many students think that shock is basically low BP. So it's not like that. Shock is a sort of reduced perfusion to organs. That's all. So whenever you have hypoperfusion to organs, you're going to result in shock. That is why you need to know about the clinical features of shock, which means patients may have a normal BP, but still they may have clinical features of shock. Patients may have low BP, but they don't exhibit any features of shock. So which means it's very clear. It's the hypoperfusion to the organs that defines shock and not the low BP alone. So which has to be very clear. So what are going to be the clinical features of shock? So there can be low perfusion to the kidneys, which can result in development of low urine output, that is oliguria, and subsequently renal failure, high creatinine as well. Renal failure. So then you can get hypoperfusion to the brain, which will typically result in altered mental status. You would have seen a lot of patients with shock that will have delirium. So that is one important problem. Then you can get hypoperfusion to the skin, which will result in cold and clammy extremities and very cold peripheries. And you can have a capillary refill time of more than 3 seconds. Even more than 2 seconds is fine. Anything more than or equal to 3 seconds is really bad. So CRT more than 3 seconds. Or you can get hypoperfusion to other organs, like probably you can think about lungs. So where they go for tachypnea, tachycardia and all this stuff. So these are some of the evidences of shock clinically. Clinically, this is how you identify a shock. And technically speaking, the only thing that can be quantified among all these things is the urine output. So in this, if you take the BP, what about the BP and shock? So let us see. BP and shock. If you see, most of the patients will have low BP. There's no doubt about that. So if you take, this is the patients with, why it's going, sorry. If you take, this is the patients with hypoperfusion, reduced perfusion to organs, low perfusion. And if you take, this is the patients who are having low BP, hypotension. So a lot of patients basically will have both low BP as well as low perfusion in patients with the shock. But there are a few subset of patients who can have a normal BP, still they may have a shock, which means they are having low perfusion. So examples of this may be probably carbon monoxide poisoning, some examples of histotoxic hypoxia where the patients are still having underperfusion to the organs, but still they are having normal blood pressure. And there are also some evidences where patients have low BP, but still they do not have any shock. In the sense, this will happen in the setting of a terminal or advanced stages of heart failure, cirrhosis, So where the patients tend to have a low BP only, 80, 60, 80, 50 will be their usual BP because their body will adapt to that low BP, and still they do have a good perfusion to the organs. They don't have any evidence of organ hypoperfusion. So BP alone is important critical care, but it's not the only thing that decides where the patient is having a shock or not. So that is why the current concern is very clear. So if you want to define a shock, as far as the definition is concerned, the first definition they give is your mean arterial pressure that is less than 65 millimeters of mercury, evidence of low blood pressure and hypotension, plus at the same time you should have evidence of hypoperfusion to the organs. So either you have to have clinical evidence of hypoperfusion or you should have some laboratory evidence of hypoperfusion. In general, we measure the serum lactate, which will be elevated in a hypoperfused state, because whenever there is hypoperfusion, there will be anaerobic glycolysis. Because of that, the serum lactate will be elevated. So either you should have clinical evidence of hypoperfusion or you should have laboratory evidence of hypoperfusion along with the MAP of less than 65. This is the current definition of shock, but this is highly questioned because there are a lot of patients who have a low BP, but still they don't have any hypoperfusion and they cannot be categorized under shock. So that's why this is under a lot of scrutiny, but still for time being, we can understand that this is what we call it as a shock in the first place. We have different types of shock and different groups of shock. We know that we have basically the hypovolemic shock. Then we have the cardiogenic shock, or we can write in this category. So how to find out each and everything. So I can write the type of shock and I can write what will be the primary issue, primary problem in that particular type of shock. Then we can talk about the cardiac index. Then we can talk about the CVP, that is central venous pressure. And we can talk about the systemic vascular resistance. So this is how you are going to really think about shock, but I'll tell you why this is not important. This is the most unimportant table as far as clinical practice is concerned, even though this is very commonly asked in exams. Number one is the hypovolemic shock, where the primary problem is volume loss. Because of the volume loss, you're going to result in reduced ventricular preload. And cardiac index will be low in this setting. And as far as the CVP, central venous pressure, is concerned, absolutely it will be low, and systemic vascular resistance will be increased because of the catecholamine surge, because of the counter-regulatory hormones. Then you have cardiogenic shock. There are many types of cardiogenic shock. Basically, we divide into two. One is called arrhythmogenic, and second is non-arrhythmogenic. Non-arrhythmogenic example is simple heart failure, where the systolic dysfunction is there. Arrhythmogenic, the main problem is reduced diastolic time. So different types are there. But here, let us take a very simple form of cardiogenic shock where the cardiac contraction is poor. So that is due to reduced contractility. That's the problem, where the cardiac index is going to be low again. The CVP will be high. That's the basis. And SVR will once again be high in this situation. And again, remember, all these values are highly variable. I'm giving only exam-related table. Then we have something called a distributive shock. You have many different types under this heading. Like, for example, you have a neurogenic shock, you have a septic shock, and again, you have something called a anaphylactic shock as well. All these things will come under the distributive shock, where the primary problem is peripheral pooling of the bed, that is peripheral vasodilation. And because of that, the blood stays in the peripheral areas and they don't come to the central circulation, so reduced preload will be there. And cardiac index here is variable. CVP is again variable, but in general, cardiac index is supposed to be normal or even sometimes increased, or even it can be decreased. So that's why I'm telling you it's variable. CVP, usually in exams, you can answer it is decreased because preload is decreased. SVR is decreased, and this is the most important reason why you develop this distributive shock in the first place. Systemic vascular resistance will be low. And next thing is the obstructive shock. Very classic example is pulmonary embolism, but it can happen in the setting of a cardiac tamponade, constrictive pericarditis, or even severe tension pneumothorax. All these things can produce an obstructive kind of a shock, where the main problem is again reduced preload to the heart. Reduced preload to the left ventricle. So because of obstruction like pulmonary embolism, which is blocking the blood flow from the right ventricle to the left atrium and then to the left ventricle, your cardiac index will be low and your CVP will be definitely high, and the systemic vascular resistance also will be high. So these are the basic differences, but this is not a very practical table in the first place. Why it is not a practical table? Because I need invasive measures to find out cardiac index, CVP, and systemic vascular resistance. So for measuring all these things, you need invasive techniques. You need invasive techniques, absolutely. So which means, for example, I'll be needing a pulmonary artery catheter, PAC, that is Swan-Ganz catheter. That's what I really need to do this. So in the setting of emergency or when I'm dealing with an ICU, this is not really practical. And yes, of course, I can find out systemic vascular resistance. What is the formula for systemic vascular resistance? It's going to be similar to that of the Ohm's law. You know what is Ohm's law, isn't it? Voltage is equal to current times the resistance. This is a simple Ohm's law. We know the circuits already. We just studied very early in your 8th standard, 9th standard. So what is the voltage here? Is the voltage difference across the resistor. So which means voltage difference can be equated here as MAP minus CVP. So is equal to, what is the current here? It is nothing but the cardiac output, that is the flow, multiplied by resistance. That is the systemic vascular resistance here. So this is a simple formula. Suppose if you want to know the systemic vascular resistance, the usual formula is MAP minus CVP divided by cardiac output. You can imagine heart like something like this. For example, you have a right heart that goes to the lungs. Then after going to the lungs, it comes back to the left heart. From the left heart, it goes back to the peripheries through aorta and multiple areas, and it's going to enter the great veins, right? It's going to enter the great veins. This is a simple circuit. Usually you apply resistance at these areas. So this is the area where you're going to apply resistance. This is the pulmonary vascular resistance. You're going to apply resistance at these areas. This is the systemic vascular resistance. That's all. If you want to know the systemic vascular resistance, you need to know the pressure difference between those two sides. So this is the arterial side. So where the average arterial pressure is mean arterial pressure, we know that. This is the venous side, and the average pressure on the venous side is going to be the central venous pressure. So this difference between the MAP and the CVP is going to be the voltage according to the Ohm's law, isn't it? And the resistance here we are talking about is the systemic vascular resistance. And the current flow, what we are talking is the, and the current flow, what we are talking here is the cardiac output that is happening. So the cardiac output is the current basically, and the voltage difference is the MAP minus CVP, and the systemic vascular resistance is what you're going to achieve based on this. Similarly, you can have formulas for the pulmonary vascular resistance also. It's very simple, isn't it, to find out pulmonary vascular resistance. So here I need to know the pulmonary venous pressure. So pulmonary venous pressure must be equal to the left atrial pressure. Left atrial pressure can be indirectly found out by using something called a pulmonary capillary wedge pressure. So I know the pulmonary venous pressure. Now I should have the pulmonary arterial pressure, that is nothing but MPAP, that is the mean pulmonary artery pressure. So by using the same formula, that is MPAP minus PCWP, that is mean pulmonary artery pressure minus pulmonary capillary wedge pressure on the arterial side minus the venous side, must be equal to the flow, that is the cardiac output. So obviously if there is no problem, then right-sided flow must be equal to the left-sided flow. That must be equal to the cardiac output. Multiplied, now it can be multiplied by the pulmonary vascular resistance in this setting. So of course, if you want to know the pulmonary vascular resistance, then your formula will be MPAP minus PCWP divided by cardiac output. That's all. This is the formula that would have been given in the many of the physiology textbooks. But what your physiology textbooks will do is, they will tell that the CVP is very, very low, negligible under physiological states. That's what your physiology textbooks will tell. Because MAP is 95, 100 means CVP will be only 3 or 4. So they will ignore the CVP and they will tell systemic vascular resistance is equal to MAP by cardiac output. This is the formula they will give. But this is not correct in critical care scenarios. Why? Because the MAP may be very low in critical care scenarios and CVP may be very high in critical care scenarios. So that difference is no longer negligible, and cardiac output also has a lot of changes in critical care. So that changes may not be negligible. And this is a very important formula to know as far as internal medicine is concerned. So systemic vascular resistance equal to MAP minus CVP by cardiac output. But the problem with finding out all these things is because I need, like an invasive technique. I need an absolutely invasive technique here, like a Swan-Ganz catheter, to find out all these things, because I need to know what is the MAP. I need to know what is the CVP. For that, I need that to find out the systemic vascular resistance. I need a Swan-Ganz catheter. So without that, it's literally impossible for me to tell what is going to be the patient's type of shock. That is why this is a non-practical table, and we need to have a very practical table for this to understand on how you're going to really diagnose a different type of shock. And that is coming right after the break. So that you can go for a break now, and you can come back. Now time is 6:50, and you can come back by 7:30 maybe. Okay. Bye-bye.